Welcome you all. Today we are having the OSWB second PG education program. It is on pediatric ophthalmology and strabismus, as all of you know. Our first speaker is Dr. Ipshita Basu. She is a consultant of pediatric ophthalmology in Disha Eye Hospitals, and she will be teaching us on squint evaluation.
Thank you, Anuradha. First of all, I thank OSWB for giving me this opportunity, because many a times when I have looked back and I have seen all these patients, then I've thought, why it was so simple. Then why didn't I follow it during my college times? Then that was the time I realized that more and more we get into our clinical experience, the chapters become our patients, the chapters become our diagnosis, and as you go through each patient, the pages on the book start getting clarity. So today, juniors, thank you all for coming, and for all those who are still coming. I am sure strabismus after the first two sessions will not be as difficult as it looks like. If anybody has a problem with the understanding or anything, please, I do not mind. Just raise your hand and I will answer. Always remember, we start with the first thing. Why am I examining this patient? What is the purpose? When we see a patient with a squinting eye, we realize that there's something that has to be done. The purpose is to understand the diagnosis. Ki hocche, we must understand what this patient has come with. We must understand that we must have a plan. And once we have a plan, when the patient is ready to hear our plan, the next is, if I am to operate, then ami kotota angle korbo. What is the angle? That is when measurement comes into the focus. And finally, at the end of everything, it is predicting the response. So when we see a patient, this is what plays behind our mind, that we understand the diagnosis, we formulate a treatment plan. And how do we do this? Surprisingly, everything starts with the history. Never ever miss any chance of asking a question to the patient. I'll tell you a small story. A small child, 2.5 years old, sitting on a mother's lap with a squinting eye. I was very happy. It was probably the third or fourth follow-up. And I knew that this child will be operated upon. While I was talking, the mother suddenly looks at me and says, "Madam, o to ekhone haatche na." So you understand, pediatric ophthalmology is all about small kids. They are on their mother's lap. You have no idea what is happening to them. So this particular history, that is a developmental history, is very important. So what does it imply? It implies that he has a cortical problem too. So that might be a satisfactory response to your surgery. You might go ahead and do a surgery, but it might not give you the response. So a simple history taking, which takes maximum, I would say, 2 to 3 minutes. You don't let the patient talk. You ask directed questions to understand what is happening. So all these points, prior treatment, many a times people have forgotten that they have had a surgery. They come to you with a subsequent squint, and then that is a time when you ask and he says, "Hey, my parents long time back had taken me for a surgery. I think so." So that is an important thing in the history part. The next, inspection. Don't move away from the patient's face. You always keep looking at the patient's face. See, a simple thing like ptosis, a head tilt, a pseudo squint. And look at the fourth picture. The child actually has a face turn. If you keep on looking at the child, you will realize that there's a left face turn. So all these things, a simple inspection gives you a good idea about what is happening. Not only that, finally what we are looking for, the tropia part. Do we understand what is tropia? Tropia means what we can see. So if there is a tropia, there is a phoria also. And the phoria is a hidden one, so we don't need to look into that right now. But this is tropia. Are we all on the same page with the diagnosis? So an eye inward is esotropia. An eye outward is exotropia. An eye to the upper side, look at the left eye. Left eye is hypertropic for this lady, and for the man, the right eye is hypotropic. So once we have taken a history, we have seen the patient. Next, what do we do? A whole lot of tests in our hand. Konta chere konta korbo. Nothing. It's a simple thing. we are assessing two parameters in the patient. One is a motor system, one is a sensory system. What is a sensory system? Sensory system is what the eye perceives. So if the eye is seeing two images, if the eye is seeing one image, so what the eye is perceiving is the sensory system. And how the eye is behaving to that sense is the motor system. Eye is straight, eye is deviated, and that is how we just broadly classify this. If you look through all the textbooks, it's impossible to do all those tests, and it's not needed. So in our clinical practice, we need to understand what we can do in our limited time to establish a diagnosis. So here the motor examination has two, you can give it a terminology. One is a qualitative and one is a quantitative. Quantitative part comes when we are absolutely formulating a treatment plan, that how much, what to expect, and qualitative is completely an assessment of the ocular motility and the cover test. Again, now come to the cover test. Again, a big thing, a big question mark. Best thing is to cover your eyes and sit down. But it's not that bad too. I have just simplified and put on just the broad terms because sometimes it is not possible for me to show pictures or videos because this is very practical oriented. But just be with me. It's like direct cover test. We saw tropia. So in a tropic patient, when a patient is having tropia, if you just flash the light and you cover one of the eyes, that is directly covering one eye, the other eye takes up fixation. This is very important for anybody. You may say that, oh, to exotropic, then why should I do it? Sometimes the eye will not move. I have seen a patient whose eye just didn't move. That becomes a restrictive pathology. So that is a time when you have to understand fixation is there or not there. So that is a direct cover test. You put your cover on one eye and the other eye takes in the focus. Cover uncover, we will keep it for the foria part. Again, we come back to the third one, alternate cover. The name itself says that alternately I am covering each eye. And why am I doing that? Any guesses? Any guesses? Any guesses? Alternate cover test. Why? Anybody, it's all right. As long as I know you all are not sleeping. Very good. If there is a fusion, and another thing is whether both the eyes are alternatingly taking up fixation. Because now you have to think that it's not the diagnosis. You are also thinking that you need a treatment. You need to go in for surgery. Which eye to select? So you constantly see that one eye is going. So this, if we play this video of mine, this eye is trying to look. So the left eye is deviated. You cover the left eye and the right eye. The left eye takes a fixation. Again, the right eye takes a fixation. So the eye, there's no way that it will maintain the alternating. If this was a very good fusion control, then either ways, whichever cover I remove, he would have retained the fixation and the other one would have a manifest tropia. Again, if the left eye took up fixation, the right eye would have gone for a tropia. So this is what we understand from an alternate cover test. So you alternately cover either of the eyes and you try to see which eye has a better fixation. So from this simple test, I just mentioned two tests, that is a direct cover test and an alternate cover test. All these things can be understood. You can understand the direction, the state of fusion, committancy, because you understand, because we do it at all gazes. We can understand laterality, that is which eye is taking up fixation, and the amount of deviation comes from prism bar. Prism bar, I'm sorry, but I purposefully omitted that because prism bar has to be a practical approach. Many of you have probably handled prisms. It is just neutralizing the angle with the strength of prisms. So eta, we are keeping this aside and we are going to the next one. Have you ever heard of Krimsky? What is it? Or modified Krimsky? Anybody out here? Who is PG third year? PG first year? আমরা কিন্তু ছাড়বো না When do you do Krimsky? Why did I suddenly jump from direct cover test to Krimsky? Yeah, sure. Excellent. But আমি তো প্রিজম দিয়েও করতে পারতাম। Krimsky কেন হঠাৎ আনলাম?
Krimsky is when we put the prism in front of the deviating eye.
Very good.
And modified Krimsky is when we put the prism in front of the normal eye to
Yes,
check for the.
excellent. But why not prism bar? Why suddenly Krimsky? Krimsky is just holding a flashlight and putting a strength of prism and trying to see angles coming together. So because the point that he wants to mention to us is because that eye is not a seeing eye. So for the PBCT, that is a prism cover test, the eye has to be seeing. So there are patients, when you go to clinical practice, you will see they want cosmetic correction. They see less in that eye. So they won't be able to fuse at a distance. Thank you.
Welcome.
So you won't be able to see at a distance. So tokon you place the prism on the seeing eye and automatically because of the light reflection, the other eye comes into focus and you can measure the angle. You understand? So there is a basic difference between a prism bar cover test and a Krimsky's test. And now this. So now from the cover test, we have jumped to the ocular motility. This is also very important. As you know, the 9 gaze, which goes by the right gaze, the left gaze, the superior and the inferior. And then there is the dextro elevation, dextro depression, levo elevation, levo depression. This is a part of ocular anatomy. I know you all must have read it. I'll just go to the clinical application. So if this child comes to you, there is a ESO deviation, cyclopelagic refraction normal, and you see all the gazes are normal. There is no overaction in any of the field. Whereas if you see this child, if you observe the primary gaze, there's an ESO. If you go to the left side of the picture, the levo version, can you see that the right eye is deviated upwards towards an angle? Can everybody see that? So which action, which muscle is overacting? Inferior oblique, excellent. So that is the position where inferior oblique overacts. So this means that when we think of a plan, we know that we have to tackle the inferior obliques or else we will not get a good result. So all our assessment, we keep harping on the same thing. Though it is from chapters, when it comes to patients, you must understand that it is a treatment plan that you are formulating. Similarly, look at this, the exotropic, and then when he goes up, the eye looks like it has deviated outwards more. And when you see the patient on the lateral gaze, you can see the inferior oblique overaction. This slide shows us very well why we need to do ductions and versions separately. I hope we are all clear about ductions being uniocular and versions being binocular. Look at this. When we were testing for the superior gaze, it looked like that right eye cannot look upwards, elevate upwards. But when you do the duction, you see that there is no restriction. So again, the diagnosis changes. Here, once you were thinking about the right eye being the culprit eye, and then suddenly you realize, no, the right eye is not the culprit eye. So with this, we come to the end of the motor test. So we have finished ocular motility. We have done a prism cover test. We understand the diagnosis. Sensory test, very frankly speaking, in a practical field, they are very less application, more of theory. All the Bielchowski's, all that after image retinal correspondence. Yes, 1 in 1,000 patients will have an abnormal retinal correspondence which will have a bad diplopia and you will be sitting with that patient for a long time. But that really does not happen in the practical field. So let us come to the basic test that we do, Worth 4-dot test. You shine a torch with 4 lights and you ask the person to see. I'll just tell you what is happening in a very simple language, a red camera and a green camera. So both our eyes are 2 cameras, a red camera taking red pictures showing 2 red lights, a green camera taking 3 pictures and showing 2 green lights. So whichever one dominates takes the white light. So either it's a 2 red, 2 green or it's a 1 red, 3 green, but we see 4 because both the cameras are working simultaneously. But when one eye deviates, the camera does not take the picture, so the only seeing eye, which is the straight eye, sees the picture, and so you get to see only one image. Either it's a 2 or a 3. So there is a suppression of that. So the retina has to do something with the image. The retina either takes that image, puts it into one, fuses into one, or suppresses the image. So that is what has happened with suppression. And if you see 5 lights, it's diplopia. We can talk about it again later. So basically, strabismus examination involves all this, but look carefully, I have included 2 very important tests, that is visual acuity and fundus examination. With this, we will go to each segment because every segment has a unique test which is different. This child, anybody diagnosis? Any diagnosis? Anybody? What is this? Is it exotropia or esotropia? Is this an adult child or infantile? So can it be an infantile esotropia? Yes? So if it's an infantile esotropia, what strikes your head? That this could be amblyopic if I don't treat it. So how do you see amblyopia? You can't ask the child to read. You just close one eye and the other eye will fixate. So that is fixation preference. What is the differential diagnosis that comes to your mind? There can be a lateral rectus palsy also. So you do a doll's head maneuver. Anybody knows the doll's head maneuver? You just turn, exactly. You turn the head so that the eye is forced to take up the abduction. What is this? Is the squint being corrected with glasses? Louder. Nobody is sleeping, no? Squint is corrected with glasses? Then what is the diagnosis? Very good. Accommodative esotropia. What is the most important test in this? I've highlighted it. Cycloplegic refraction. Done with what? Atropine. Does the diagnosis change? What does the diagnosis change to? The child is on follow-up, has been given glasses, and she still has ESO with glasses. So it becomes partially accommodative esotropia. Now the challenge is to treat the patient. You cannot keep the patient squinting. So you do a prism cover test. So you really understand in the OPD, the moment you see the patient, you don't need to do everything. So you do the prism cover test and you realize what is the target angle and how you will approach surgically. Next, do you see any difference between the 2 eyes? Does the upper position look straight to you? Yes or no? Does the lower position look straight to you? Yes. So that is straight for distance, ESO for near. So that is a point where you do an AC by A ratio. Did you hear about AC by A ratio before? So that means you're converging more for one diopter of accommodation. If I converge 10 degree, another person is converging 20 PD. So obviously it is looking more. Moment you are accommodating, you are looking more. There is a particular way you measure. Any idea? Any idea? This side. Ei dikhte ke bolo. AC by A ratio is measured by, see, even if I show you the formula right now, you all will not retain it. So the important thing is to understand that I will measure the deviation, again put +3 diopters so that I do not accommodate, and again measure the deviation. If my 2 deviations are different, it implies something. If my 2 deviations are not different, it implies something. Read it up. Okay, so this is okay. This is where you see infantile esotropia with inferior oblique overaction. This particular test, if you do, you will see that there is a restriction of movement. So the moment you get restriction of movement or you get incompetency, that is the time a special test comes into focus, that is a force reduction test. That is to see whether it is paralytic etiology or restrictive. Most of the terminologies that we use are very simple. It's only you need to apply it to a particular situation. So when we were talking about the strabismus examination, you see a patch test is when we want to dissociate distance and near. So there is a person who is having a huge deviation at distance and similar deviation at near. We are not bothered. We know what angle to operate upon. A huge distance in distance, but with very small angle in near. That is where the problem is. You do not know which angle you will be taking. Do you take the distance angle or do you take the near angle? So you do a patch test. And the patch test, if it removes the fusion, it just makes it pseudo-divergence. So it is pseudo-divergence excess. So again you come back to basics. So again you're simple. But there is a special occasion when even after doing a patch test, there is no difference. The distance and the near stays the same. That means the patient is has a large angle for distance, but for near it has a small angle. So these are the times when you need to specially think, because as I keep saying, you are going to operate on this person and give good results. Similarly, this particular thing, if you have a V pattern, you need to understand that your measurement should be in the up gaze as well as the down gaze to understand the V pattern, because A, you need to address that. B, if there is an inferior oblique overaction, you can always handle that. But if there is not an inferior oblique overaction, you'll have to again think of what to do with the muscles so that the V pattern gets abolished. This will go off, and then again this is again another exotropia, but then you can see a limitation. While the person wants to see nasally, there is a adduction of the right eye, of the left eye, sorry, and even the even in downward gaze there is a restriction. So obviously we understand it's a third nerve palsy which has partially recovered, and here also we get to do the same test, which is the force reduction test. When we come to vertical strabismus, it gets complicated. Horizontals are much better to handle, but again fixation preference for any child is mandatory. Again, this patient, what is the diagnosis? Is it orthotropic or hypertropic or hypotropic? Hypo. And what is the commonest position of diagnosis that we get with this? See, the child cannot look up. Here the young boy is looking straight and he is hypotropic, but the child is looking up and there is an elevation restriction. That is monoocular elevation deficiency. There also we need to do a force reduction test to understand whether there is a restriction or a paralysis, and that's how you change from inferior rectus recession to a transposition surgery. When we come to vertical strabismus, there is an important thing that we need to understand, and every time we see this Parkes 3-step test, we keep up thinking what goes up and what goes down. Definitely, Bilchowski was very simple, and he kept it as smiling as that boy is. You tilt the head and you see what the obliques are doing, because it is the oblique who is responsible for the intorsion and the extorsion. Always remember, when you tilt the head, the eye tends to fall out. So anybody who is this side, on the side of the falling head, the superior is an intorter. He will turn the eye inside. And similarly, the inferior oblique will extort. So turn the eye opposite side. It looks complicated, but once you put your mind to it and see what exactly is happening, you will understand what Bilchowski wanted to say and why Parkes modified it. This is very difficult to make you all understand in an auditorium, definitely, but it is something which is very simple to understand when you see a patient. You see a patient, which eye is hypertropic and which eye is hypotropic. Always remember, it is the hypertropic eye, that is the weakness of somebody is being portrayed. So either it is weakness of the same set of the muscles of the depressors or the antagonist. So that is how 4 muscles become 2 when you see the gaze and becomes 1 when you do a tilt test. Okay, so I know it was a run through, but the understanding that when you approach a patient with strabismus, it is important to highlight the basic things, that is the history, the visual acuity, the inspection, trying to establish a diagnosis. And when you try to establish a diagnosis, if you have a differential, you have to apply a particular test to it. Every special diagnosis, every special entity has a particular test to establish the diagnosis. So you use that and you come to a diagnosis. Now just for the house, what does the first picture show you? The one on the right, the young girl? What is this? Inspection? It's a ptotic eye. Where is the eyeball? Outside. So what do you think it is? Excellent. The one to the left, the boy there, is he trying to look to his right? No, he is trying to look to the right. That is his right gaze. Does his palpebral fissure narrow down? Is this narrow? Is this, do you think that the globe is retracted as compared to the right eye? So if there's a globe retraction, narrowing of palpebral fissure on the right gaze, which diagnosis does it follow? Excellent. What about this lady? She also is trying to look to her left. Her right eyeball is not moving. And there's a downshoot. All these downshoots, most of the times, are a part of the Duane's retraction syndrome complex. Does this give anybody a clue? Where is this patient looking? To the right or left? Left. Has his right eyeball moved? Not at all. Do you see a scar out here? So the patient had a grinder injury and there was a medial rectus avulsion. Okay? So with this, I conclude my run with strabismus. With this run, I do not think much has to be understood, but definitely there is a whole world out there. Please pause, see the patient and explore. Thank you.
Thank you, Ipshita, for that extensive squint evaluation. I think now you can at least answer a few questions when you are asked about squint. I hope so. Did you get the confidence? Sir, before going to the next talk, I would invite our chairperson, sir, Dr. Ashim Ghosh, sir, and our esteemed panelists, Dr. Rupam Roy, Dr. Rajesh Mojumdar Chaudhary, Dr. Smriti Rani Srivastav, and Dr. Manish Singh. Now, the next equally important topic, management of squint, by none other than our Shumon sir. He has been our sir for so many decades. Also invite Dr. Pinaki Sengupta sir for his, and I would like to invite his comments for the talks. Thank you.
Good evening everybody. Respected Asim sir, আর আমার প্রচুর সিনিয়র এবং কলিগস দেখতে পাচ্ছি, স্মৃতিদি আছে, তানিয়া, রূপমদা, পিনাকিদা, যাদের সঙ্গে একসময় প্রচুর কাজ করেছি আরআইওতে, অ্যান্ড মাই ডিয়ার স্টুডেন্টস। আর তার সঙ্গে এখানে আজকে অনেক দিন বাদে একসঙ্গে বলার স্কোপ পেলাম উইথ ইপসিতা। ইপসিতা ইজ মাই, মানে মেডিকেল কলেজ ইজ মাই সেকেন্ড হোম অ্যান্ড আরআইও ইজ মাই ফার্স্ট হোম। তো ইপসিতা হচ্ছে আমার কলেজের জুনিয়র, অনুরাধা যেমন জুনিয়র, ইপসিতা আমার কলেজের খুব ক্লোজ জুনিয়র। সো আমার কাজটা অনেকটা সহজ করে দিয়েছি ইপসিতা, বিকজ with elaborate description, because for squint cases, for all practical purpose, for your examination and diagnosis is the ultimate thing. And if a external examiner with a vast knowledge of squint will come, then he may ask you to hold the prism at least. At least you must know how to hold the prism. At least you must know how to do the cover test. What is the indications of cover test? What is the indication of cover uncover test? What are the indications of alternate cover test? Why do we ask for occlusion or patching? What Ipshita has told you. If it's a severe fusional amplitude, then to break that fusion, alternate cover test may not be sufficient. Particularly in case of, lastly, she told you a distant near disparity, where exotropia is big in distance, but very small amount in near. That distant near disparity can be due to accommodative component, can be due to a fusional component. So you have to do a monocular patching, and again you re-examine the case. If it is a fusion, then the distant near will be almost equal. But if it is accommodative, then you have to do for this AC by A ratio testing. All these are not theoretical, because in your practical cases you may find a distant near disparity, and that will be a difficulty thing, because on what number will you operate, for the distance or for the near? That is, for that, with this brief introduction, I will just go straight forward to the management of squint. Management of squint. After you come to a diagnosis, either it is a concomitant or a incomitant squint, you diagnose the case and you actually calculate the numbers. Then what is your next plan? The examiner will ask you, now what will you do? Will you send the patient, or let you be a PGT coming firstly to a unit that has a squint cases, squint clinic. So the SIR is not there, the RMO is also not there. So you have to see so many of cases. All after 3-4 pediatric cases, one squint case has come. Ki korbo. So forget about everything. When a squint case will come, if you are alone in your clinic, ask for a cycloplegic refraction. You will be 100% correct. So, starting with the management. So, for your examination also, first say, sir, full cycloplegic refraction. And you will be 100% correct, nobody will question you. So, what are the objectives and principles? The first is the reversal of the deleterious sensory effects, particularly if there is any amblyopia, is there any suppression, and next, alignment. Because squint also has a cosmetic thing, and if you just break up this thing, prioritize this thing. First one is stereo acuity. Now, on the squint examination, if you go to RIO squint clinic, there is a stereo acuity card. আমাদের ছিল না একটা? হ্যাঁ টিওনো কার্ডস আছে তো। So, in case of intermittent exotropia particularly, when there is a dilemma, what will you do this case? Every time after 3 months, 6 months, the patient will come to your clinic. You must see the stereo acuity. If the stereo acuity goes down, or if the amount of squinting time increases, that may be the indication for early surgery. So first you think of stereo acuity, and after the management, our best possible goal is to give the proper stereo acuity. Second one is definitely amblyopia therapy. Amblyopia can be due to so many other causes, and one cause is definitely squint. And if there is any media opacity, you all know that you have to correct that. And regarding this amblyopia, you must correct the refractive error, because without refractive error, squint evaluation is incomplete. When patient came to you, you have to evaluate the squint with the glass and without glass. And definitely you ask for a best corrected visual acuity, and patient should wear the glasses. For paralytic squint, if there is any confusion or diplopia, you must alleviate those symptoms. And last one is cosmesis. Now, for the phoria, usually the phoria patients are coming with nagging headaches. They may have some double visions in the evening, particularly এখন অনেকেই আছে যারা কিছুদিন আগে পর্যন্ত ড্যামসের কোচিং আর হাবিজাবি পড়ছিলিস, সারাদিন মোবাইলে এমসিকিউ। আমার এখনও ওখানে স্টুডেন্টরা আছে, স্যার মাথা ধরছে, সন্ধ্যেবেলা সব ডবল দেখছে, ভাই একটু বড় স্ক্রিনে দেখ। সো দিস ইজ দ্য ওয়ে যে তাদের রিফ্র্যাক্টিভ এরার কারেকশন ইজ আ মাস্ট, অ্যান্ড তার সঙ্গে কিছু অর্থোপটিক্স এক্সারসাইজ আমরা প্রেসক্রাইব করি। সামটাইমস ইট ক্যান বি আ ক্যাট কার্ড, or it can be a simple pain push-ups that can help. Or if there is any severe convergence or divergence weakness, you can also advise flippers. There are prism flippers for divergence and convergence, and for near and distance you can prescribe flippers. And definitely if you are in a RIO setup, you have a synaptophore with you, you can do those exercises, this convergence and divergence exercise, on a synaptophore. And last one is therapeutic prisms. Sometimes it may happen, case of paralytic squint come to you, cannot accept the patching. In that case, you may have to describe press-on prisms or Fresnel prisms. Refractionের যেটা কেউ দেখেছিস তোরা, মানে ট্রায়াল বক্সটা, দেয়ার আর প্রিজমস ওভার দেয়ার। সো প্রিজমস কী করে দেখতে হয়, স্যারের কিন্তু ইজ আ ফেভারিট কোয়েশ্চেন, অ্যাটলিস্ট আন্ডার গ্রাজুয়েট লেভেলে তো আমাদের স্যার পড়াতে নেই। সো সেটা কিন্তু জেনে নিতে হবে, হাউ টু হোল্ড দ্য প্রিজম, মানে ওই রিফ্র্যাকশন ট্রায়াল সেটের প্রিজমগুলো, আমি আমাদের প্রিজম বক্সের প্রিজম বলছি না। তো সেই প্রিজমসগুলো ক্যান বি ইউজড ফর প্রেশন প্রিজমস, অ্যান্ড অনেক সময় আমাদের ফেনেল প্রিজম ইউজ করতে হয়। নাও হেটেরোট্রোপিয়া, কাম টু দ্য মেন পয়েন্ট, either it can be concomitant or can be concomitant, paralytic or restrictive. Now again the treatment of amblyopia, non-surgical therapy মধ্যে occlusion and atropine penalization. It can be spectacle or prism, already I have described. It can be Botox, particularly in case of early paralytic squint. If there is any suspicion of restrictive, like a lateral rectus palsy with medial rectus restriction, you may think, so you can put a Botox injection over there. Or sometimes what happens, after evaluating a concomitant squint, you do a alternate cover test with a prism in front. Now at the end point, when you think the squint এখন আমার নিউট্রালাইজ হয়েছে, লাইক ইন 40 prism তখনও হালকা স্কুইন্ট আছে, অ্যান্ড অন 50 it got reversal. So 45 is the ideal number. So with that prism in front, you must remove the cover. Again you ask the patient to look at the Seller's chart, and you must ask whether the patient sees single or double. That is we call fusing. If patient sees single, then it's okay, you straightforward go to surgery. If patient can say, না স্যার আমার মনে হচ্ছে আমি দুটো দেখছি, বাট ডোন্ট আস্ক বারবার জিজ্ঞেস করলেও কিন্তু সেকেন্ড ইমেজটা খুঁজবে। এভরিবডি উইল সে সেকেন্ড, কিন্তু সেটা ও ম্যানেজ করতে পারে। অ্যান্ড নেভার এভার আস্ক দিস কোয়েশ্চেন আফটার সার্জারি। If you ask this question, the patient will be on you for the next of your life. So never ever ask this question. Okay? এবং এটা আমার অভিজ্ঞতা আছে, আমি যখন সংকলনের ট্রেনিংয়ে ছিলাম, একটি পেশেন্ট কেকেভির ঘরে রেগুলার আসতো, সে হচ্ছে উত্তরবঙ্গের পেশেন্ট, হ্যাঁ, ওর চোখ স্ট্রেট হয়ে গেছে, বিয়ে হয়ে গেছে, ম্যাডাম আমি না দুটো দেখছি। ম্যাডাম একদিন পারলো না, লাস্টে বললো শোনো আর কাউকে বলো না, ডিভোর্স হয়ে যাবে। কারণ ইউজুয়ালি কনকমিটেন্ট স্কুইন্ট তো আলটিমেটলি সার্জারির পর দেয়ার ইজ এ নিউ সেট অফ অ্যারেঞ্জমেন্টস না, তো ব্রেনকেও সেটা অ্যাডজাস্ট করতে হয়। সো ইনিশিয়াল ফেজে দে ক্যান হ্যাভ আ ঘোস্ট ইমেজ। সো ইফ দে লোকেট দ্যাট ইমেজ না, তো সেকেন্ড ইমেজটাও খুঁজেই পাবে। সো নেভার এভার আস্ক দিস কোয়েশ্চেন আফটার সার্জারি। So come to the surgical treatment. Surgical procedures either can be resection or can be shifting of point of muscle attachment, or it can be a Fadden procedure. And কোন muscle choice করবো, কোন eye choice করবো, whether it is a uniocular surgery or is a binocular surgery, and adjustable suture is another technique. Now mainly 4 different mechanisms সার্জারিটা কাজ করে। First one is রিসিশন, যেখানে স্ল্যাকেনিং হচ্ছে মাসলটাকে, টাইটেনিংয়ে হচ্ছে রিসেকশন আর প্লাইকেশন, রিডিউসিং দ্য মোমেন্টাম যেখানে ফ্যাডেন প্রসিডিওর করছি, অ্যান্ড চেঞ্জিং দ্য ভ্যাক্টর যেখানে আমি ট্রান্সপোজিশন করছি। অ্যান্ড জেনারেল গোলস আর রেস্টোর দ্য বাইনাকুলার ভিশন, টু ইমপ্রুভ দ্য অকুলার অ্যালাইনমেন্ট, টু এনলার্জ দ্য ফিল্ড অফ ভিশন, অ্যাবনর্মাল হেড পশ্চার কারেকশন, অ্যান্ড ইমপ্রুভ কসমেসিস। নাও কিছু ফ্যাক্টরস যেগুলো আমাদের ইনফ্লুয়েন্স করে টু ডিডাক্ট দ্য সার্জিক্যাল নাম্বারস। Now, first one already, if it has told you that target, always use a accommodative target. Accommodative target means either it is a Senate shirt or it can be a TV screen. For pediatric patient, we used to use a TV screen. Kintu don't use the torchlight because that can underestimate the amount of squint. After surgery, তুই দেখলি যে তুই হিসাব করলি একটা 40 prism squint, তুই সার্জারি করলি, করে আবার দেখলি পরের দিন সকালবেলা পেশেন্ট এলো, স্যার আমার না সোজা হয়নি, এখনও 10 আছে। সো অলওয়েজ ইউজ দ্য সেলাইশিয়ার, ঠিক আছে। নেক্সট ওয়ান হচ্ছে মেথড অফ টেস্টিং, যেটা অলরেডি আগে একবার ডিসকাস হয়েছে। অল্টারনেট কভার তো করবই, কিন্তু তারপরেও ডিস্ট্যান্স নিয়ে ডিসপ্যারিটি পেলে মনোঅক্লুসার প্যাচ করে দেখতে হবে। আর প্রিজম প্লেসমেন্ট, এটা নিয়ে পরীক্ষায় আমাদের সময় একটা কনফিউশন থাকতো। দের আর 3 পজিশনস অফ প্রিজম প্লেসমেন্ট। একটাকে বলে প্রেন্টিস পজিশন, একটাকে বলে হচ্ছে মিনিমাল ডেভিয়েটেড পজিশন, আর একটা হচ্ছে ফ্রন্টাল প্লেনে। নর্মালি আমরা গ্লাস প্রিজম একদম ডান দিকেরটা হচ্ছে প্রেন্টিস পজিশন, গ্লাস প্রিজমগুলো আমরা প্রেন্টিস পজিশনে দিতাম, সেখানে হচ্ছে আই বলের সাথে পোস্টার সারফেসটা প্যারালাল থাকে। আর নর্মালি আমরা প্লাস্টিক প্রিজমসটা দিই হচ্ছে ফ্রন্টাল প্লেনে, যেখানে মানে এটা এই ফ্রন্টাল প্লেনের সাথে প্যারালাল থাকে দ্য পোস্টার সারফেস, ঠিক আছে। আমরা যেগুলো প্লাস্টিক প্রিজমস ইউজ করি সেগুলো এভাবে ইউজ করা হয়। নেক্সট ওয়ান হচ্ছে পেশেন্ট ফ্যাক্টর। পেশেন্ট ফ্যাক্টরের মধ্যে অ্যাকোমোডেটিভ ফ্যাক্টরস, ফিউশনাল ফ্যাক্টরস অ্যান্ড AC/A রেশিও, এগুলো আমাদের কনসিডারেশনে রাখতে হবে বিফোর ক্যালকুলেটিং দ্য নাম্বারস। অ্যান্ড কিছু অ্যানাটমিক ফ্যাক্টরস আছে, লোকেশন অফ দ্য ইকুয়েটার, অ্যান্ড দেয়ার ইজ আ, আমি যখন বইয়েতে পড়েছি এবং এটা অনেক সময় আমার মনে হয়েছে যে হতে পারে, আমরা যে মেজারমেন্টটা করি না, ইজ আ রাউন্ড সারফেস। সো ওয়েদার উই টেক দ্য কর্ড লেন্থ or we'll take the arc length, that is important, but that is more of theoretical type. And surgical factors এর মধ্যে একটা তো টাইমিং, যত আর্লি সার্জারি করবো, বাচ্চাদের ক্ষেত্রে পার্টিকুলারলি ইনফ্যান্টাইল ইসোট্রোপিয়া, সেক্ষেত্রে স্টিরিও অ্যাকুইটি বেটার রিগেন করার চান্স থাকে। কিন্তু বাচ্চাদের যখন উই প্ল্যান ফর সার্জারি, উই হ্যাভ টু কিপ ইন মাইন্ড দেয়ার আইবলস আর স্মলার ইন সাইজ, সো ইকুয়েটার ইজ closer to the adult calculation, so you have to keep in mind, মানে post equator if we go then the muscle will not work, retroequatorial যদি হয়ে যায়। একটা বাচ্চার ক্ষেত্রে আমি যতটা ক্যালকুলেট করব, অ্যাডাল্ট সাইজে গিয়ে দ্যাট ক্যান বি আ ডিফারেন্ট ওয়ান, সো ইউ হ্যাভ টু কিপ ইন মাইন্ড দোজ নাম্বারস। একটা সার্জিক্যাল নাম্বারসের একটা চার্ট আমি দিয়ে রেখেছি, দ্যাট ইজ আ ভেরি বেসিক চার্ট, when how much number or what amount of medial rectus resection or resection will give how much amount of prism correction. Usually আমরা একটা রাফ ক্যালকুলেশন করতাম যে per millimeter of medial rectus will give a 3 prism diopter and per millimeter of lateral rectus will give you a 2.5 prism diopter. But এটা is a very rough calculation for our all practical purpose. For your exam purpose, you better to give a AO nomogram. American Academy খুলবি লেটেস্ট এডিশন, তাতে যে নোমোগ্রামটা দেওয়া আছে, ইউ ক্যান সে দ্যাট ওয়ান, এবং আমার মনে হয় সেটাই বেটার, বিকজ এক্সামিনার উইল আস্ক ইউ যে ফ্রম ওয়ার ইউ গেট দ্য নাম্বারস। বাট ফর আ সার্জন ওয়েন ইউ প্র্যাকটিস স্কুইন্ট, পরীক্ষার জন্য নয় কিন্তু, ইফ 1% of you ultimately become Tanmoy, Anuradha or Ipshita, a pediatric ophthalmologist, then you have to do the squint surgeries. So you have to calculate your number. Because there is সবার সুচার দেওয়ার একটা টেকনিক আছে, আমি কিছু টাইট করি বেশি, কেউ একটু লুজ করে, সো আলটিমেটলি পার মিলিমিটার অফ মিডল লেকটাস ফর ইউ গিভ হাউ মাচ প্রিজম ডায়াপ্টার কারেকশন, দ্যাট উইল বি ইয়োর আলটিমেট ক্যালকুলেশন। এগুলো ডিটেলসে আর যাচ্ছি না। নেক্সট যাচ্ছি যে আমরা যখন সার্জারি করব, আইদার ইট ক্যান বি এ ইউনিওকুলার সার্জারি অর ইজ আ বাইনোকুলার সার্জারি। নর্মালি ইউনিওকুলার সার্জারি আমরা প্রেফার করি বিকজ ব্লক দিয়ে করি একটা চোখ, বাট বাইনোকুলার সার্জারি প্রেফার্ড বিকজ বাইনোকুলার সার্জারিতে দুটো দিকের যে প্যালপেব্রাল অ্যাপারচারের যে ডিফারেন্স, দ্যাট অলমোস্ট ইকুয়াল ন্যারোয়িং বা ওয়াইডেনিং হয়। কসমেস ইজ বেটার অ্যান্ড দ্যাট ইজ মোর অফ কমিটেন্স ওরিয়েন্টেড। বুঝতে হবে না মানেটা, কথাটা মনে রাখ, দ্যাট ইজ মোর অফ কমিটেন্স। বোঝাতে গেলে তো একটা গোটা ক্লাস লাগবে। পিনাকিদা অলরেডি খিস্তি মারছে যে এত এত পড়ালে হবে না, অল্প অল্প পড়াতে হবে, অল্প অল্প পড়ো। তো ঠিক আছে, সো ইট ইজ মোর অফ কমিটেন্স ওরিয়েন্টেড, সেই জন্যে আমরা বাইনোকুলার সার্জারি প্রেফার করব। আর একটা জিনিস যেটা আমরা বলি, ইফ দেয়ার ইজ মোর কারেকশন নিডেড ফর নিয়ার, ডু সার্জারি অন মিডিয়াল লেকটাস। ইফ দেয়ার ইজ মোর কারেকশন নিডেড ফর ডিস্টেন্স, do surgery on lateral lectures. That is also a very theoretical thing. If you have a squint case, or if আমি জানি না এখন স্যার কীভাবে দেওয়া হয়, চিট লং অ্যাটলিস্ট আমাদের সময় যেটা ছিল, আমরা চিটটা খেয়ে নিতাম, বিকজ উই নো যে ওটাই আমার কেস, আমি ওটাতেই যাবো। সো ইফ ইউ প্রিপেয়ার স্কুইন্ট কেস, দেন ইউ গো থ্রু দিস। সো দেয়ার আর অ্যাপ্রোচেস যে আমি কীভাবে মাসেলটা হুক করবো। ইট ক্যান বি আ লিম্বাল অ্যাপ্রোচ অর ইট ক্যান বি আ ফর্নিক্স অ্যাপ্রোচ। ফর্নিক্স অ্যাপ্রোচ হ্যাজ আ অ্যাডভান্টেজ বিকজ এখানে অনেক বেশি কনজাংটিভা থাকে। ইট ক্যান বি আ সুচারলেস সার্জারি, মানে আউটসাইড সুচার নাও দিতে হতে পারে। লিম্বাল অ্যাপ্রোচ ইজ বেটার ফর বিগিনার্স, অ্যান্ড ইফ ইউ অ্যাপ্রোচ মোর দ্যান 2 muscles from the same incision, like lateral rectus and infraoblique, or lateral rectus and supraxis, then limbar approach will be better. আর্ক অফ কন্ট্যাক্ট একটু ছোট করে বলে রাখি, বিকজ আর্ক অফ কন্ট্যাক্ট, আমি ছবিটাতে যাই, পয়েন্টারটা, মানে এই যেখানে ইনসারশন হয় ফ্রম দেয়ার যতদূর পর্যন্ত গ্লোবে মাসেলটা টাচ করে থাকে, দ্যাট ইজ কল আর্ক অফ কন্ট্যাক্ট। আর্ক অফ কন্ট্যাক্ট ইজ ভেরি মাচ ইম্পর্টেন্ট ফর দ্য মাসেল অ্যাকশন। ইফ উই রিডিউস দ্য আর্ক অফ কন্ট্যাক্ট, দেন দ্য মাসেল পাওয়ার উইল বি রিডিউসড, এটা একটা থিং। অ্যান্ড সেকেন্ড ওয়ান হচ্ছে রোটেশনাল ফোর্সের সাথে মাসেল আর্মের লেন্থ ইজ অলসো ইম্পর্টেন্ট। সো দিস টু থিংস আর অ্যাকচুয়ালি নিডেড ফর আন্ডারস্ট্যান্ডিং দ্য ওয়াই রিসেকশন strengthens the muscle and recession weaken the muscle. Because recession what will happen, will shift this arc of contact, আমরা পেছনে সরিয়ে দিচ্ছি, তাহলে arc of contact will be reduced, so there will be a less effect of that muscle. And resection এ আমরা মাসেল আর্মটাকে ছোট করে দিচ্ছি, so there will be more power of that muscle. So next, for surgical management, there are basically 2 procedures for your exam purpose. One is weakening procedure, another is strengthening procedure. So weakening procedure is conventional resection. It can be adjustable also. It can be a hangback resection. It can be myectomy or myotomy. So conventional resection আমরা কি করছি, আমরা মাসেলটাকে from the insertion we cut after giving a suture, bow tie knot suture দিলাম, then we calculate the numbers যে we have to do a 6 mm resection or 4 mm resection, so সেই অ্যামাউন্টে পেছনে গিয়ে স্ক্লেরায় বেঁধে দিলাম। হ্যাংব্যাকের ক্ষেত্রে আমরা যেটা করি যে আমরা সুচারটা ইনসারশনেই রাখছি, মাসেলটাকে স্ল্যাক ডাউন করে দিলাম ব্যাকে। অ্যান্ড হেমি হ্যাংব্যাকে হচ্ছে ইনসারশন আর যেখানে অ্যাকচুয়ালি চাইছি এর মাঝামাঝি কোথাও রাখছি। লাইক ইউ হ্যাভ টু ডু আ 10 mm রিসিশন, তুই দেখছিস 10 mm রিসিশন করতে গিয়ে অনেকটা ব্যাকে যাচ্ছি, আমি দেখতে পাচ্ছি না, বিকজ উই হ্যাভ টু কিপ ইন মাইন্ড স্ক্লেরা কোন কোন জায়গায় থিন, পারফোরেশন যেন না হয়। আরডিতে পারফোরেশন হলে কোনো চাপ নেই, অসীম স্যার আছে, শ্যামাদা আছে, ভেতর দিয়ে ঢুকবে, রেটিনা জুড়ে দেবে, ঠিক আছে। স্কুইন্টে হলে ইয়ার স্যার ফুটো হয়েছে, সো ডোন্ট ডু দিস। স্কুইন্ট সার্জারিতে ইউ মাস্ট বি ভেরি কশাস রিগার্ডিং সুচারিং, এবং খেয়াল রাখতে হবে যেখানে মাসেলগুলো ইনসার্টেড হয় দ্যাট ইজ দ্য থিনেস্ট এরিয়া অফ স্ক্লেরা। সো রিসেকশনে যখন আমরা মাসেল সুচার করবো, ইউ মাস্ট কিপ আ স্মল মাসেল স্টাম্প ওভার দেয়ার, যাতে পারফোরেশন না হয়। আর অনেক সময় খুব লার্জ অ্যামাউন্ট অফ রিসিশন ইফ ইউ গো ভেরি বিয়ন্ড সেখানে অনেক সময় দেখা যায় না, ভিজিবিলিটি ইজ আ প্রবলেম, মাইক্রোস্কোপে দেখলেও প্রবলেম হতে পারে। সো ইন দ্যাট কেস ইউ ক্যান গো ফর আ হেমি হ্যাংব্যাক রিসিশন যেখানে স্ল্যাক হয়ে যাচ্ছে। সো দিস ইজ আ নর্মাল রিসিশন, দিস ইজ আ হ্যাংব্যাক রিসিশন। অ্যাডজাস্টেবল সুচার টেকনিক এই পরীক্ষার জন্য লাগবে না। রেট্রো ইকুয়েটোরিয়াল ফ্যাডেনটা লাগবে, বিকজ ফ্যাডেনে কি হচ্ছে, আমরা আর্ক অফ কন্ট্যাক্টে এখানে রিসিশন করছি না, কিন্তু ইকুয়েটারের পোস্টেরিয়রলি গিয়ে আমরা একটা সুচার করে দিচ্ছি। দেন হোয়াট উইল হ্যাপেন, দিস ইজ দ্য আইবল, this is the lateral rectus muscle or medial rectus muscle. Say it is the medial rectus muscle. So when it is straight, it will force, the force is full amount. But when adduction, there will be a new point of insertion, যেটা retroequatorial. তখন adduction position এ ওর কিন্তু মুভমেন্টটা কমে যাবে। It is useful if you have a high AC by A ratio accommodative squint যেখানে distant near disparity হয়ে বসে আছে, মানে ডিস্ট্যান্সে স্কুইন ইস্যু ইজ লেস, নিয়ারে অনেক বেশি, যেটা বাইফোকালস দিয়েও কারেক্টেড হচ্ছে না, সেখানে তোমায় সার্জারি করতে হবে। ইন দ্যাট কেস ইউ ক্যান ট্রাই ফ্যাডেন প্রসিডিওর। সো দিস ইজ আ, যখন মাসলটা ঘুরছে, যখন আইবলটা ঘুরছে, তখন দিস উইল বি আ নিউ ইনসারশন পয়েন্ট। ইন্ডিকেশনসে আর যাচ্ছি না। রিসিশন অফ ভার্টিক্যাল রেক্টার ক্ষেত্রে খেয়াল রাখতে হবে, দেয়ার উইল বি আ, ফর ইনফিয়ার রেক্টাস দেয়ার উইল বি আ লকউড লিগামেন্টস, অ্যান্ড ফর দ্য সুপিরিয়র রেক্টাস দেয়ার ইজ উইনটলস লিগামেন্টস। যারা অকুলোপ্লাস্টি অলরেডি হয়ে গেছে, দে উইল নো দ্য ওয়্যার ইজ উইনটলস লিগামেন্ট, বিকজ এলপিএস রিসেকশনের সময়ও সেটা খেয়াল রাখতে হয়, সো দ্যাট ইউ ডোন্ট ইনজিওর দ্যাট মাসল। আর মার্জিনাল মায়োটমি হচ্ছে যেখানে মাসলটাকে আমরা মাল্টিপল ছোটো ছোটো স্নিক্স দিয়ে দিচ্ছি, সেটাও ইজ আ সর্ট অফ উইকেনিং প্রসিডিওর। নেক্সট ওয়ান হচ্ছে রিসেকশনে এখানে একটা লিমিটের ব্যাপার আছে, ম্যাক্সিমাম মিনিমাম লিমিট রিসিশনে মিডিয়াল রেক্টাসের ক্ষেত্রে ম্যাক্সিমাম রিসিশন উই ক্যান ডু ইজ 6 মিলিমিটার, বিকজ আমি প্রথমেই বলেছি উই ক্যানট মুভ দ্য মাসেল রেট্রো ইকুয়েটোরিয়াল করিয়ে দেয়ার উইল বি নো অ্যাকশন অফ দ্যাট মাসেল। অ্যান্ড ল্যাটারাল রেক্টাসের ক্ষেত্রে ম্যাক্সিমাম লিমিট ইজ 10 millimeter, অ্যান্ড ফর রিসেকশন ফর মিডিয়াল রেক্টাস এগেন দ্যাট ইজ 5 to 6 millimeter, অ্যান্ড ফর ল্যাটারাল রেক্টাস ইজ 8 to 10 millimeter. অ্যাডভান্সমেন্ট যখন একবার অলরেডি সার্জারি হয়ে গেছে, উই হ্যাভ টু গো ফর আ রিসার্জারি, উই ক্যান লিম্বাসের আরও কাছে নিয়ে চলে আসতে পারি অ্যাটাচমেন্টটা, দ্যাট ইজ কল অ্যাডভান্সমেন্ট। ডাবল ব্রেস্টিং অ্যান্ড টাকিং অনেক সময় করা হয়, পার্টিকুলারলি সুপিরিয়র অবলিক মাসেলের ক্ষেত্রে করা হয়। আর মাসেল ট্রান্সপোজিশন পার্টিকুলারলি প্যারালাইটিক স্কুইন্টে করা হয়। প্যারালাইটিক স্কুইন্ট, ইনকমিটেন্ট স্কুইন্ট যখন আমরা এক্সামিন করব, দুটো এক্সামিনেশন উই হ্যাভ টু ডু। ওয়ান ইজ ফোর্স ডাকশন টেস্ট, যেখানে আমি কনফার্ম করছি ওয়েদার ইজ আ রেস্ট্রিকটিভ প্যাথোলজি অর ইজ আ প্যারালাইটিক প্যাথোলজি। নেক্সট ইজ ফোর্স জেনারেশন টেস্ট। ধর আমি পেলাম ইজ আ ল্যাটারাল রেক্টাস পলসি, দেন ইউ হোল্ড your forceps over the lateral rectus insertion. Now ask the patient to look laterally and you feel the tuck. If you feel a tuck, then that means lateral rectus has some action. Then next procedure will be depending on whether lateral rectus is totally flaccid or lateral rectus has some action. And you can plan transposition on this muscle. It can be naps procedure, যেখানে দুটো মাসেলকে খুলে একটা মাসেলের গায়ে লাগানো হচ্ছে naps. It can be Jensen's procedure, যেখানে দুটো মাসেল হাফ হাফ করে বেলি কেটে লাগিয়ে দিচ্ছি, অ্যান্ড অর ইট ক্যান বি আ হ্যামেলসিমস প্রসিডিওর, যেখানে হাফ হাফ বেলি কেটে সেকেন্ড মাসেলটার গায়ে লাগানো হচ্ছে। সো দিজ আর অল ট্রান্সপোজিশনস। অ্যান্ড লাস্ট হচ্ছে ভি অ্যান্ড এ প্যাটার্ন, সেখানে অলরেডি ইপসিতা ম্যাডাম হ্যাজ টোল্ড ইউ দ্য ভি প্যাটার্ন ক্যান বি ডিউ টু ইনফেরিয়র অবলিক ওভারঅ্যাকশন অ্যান্ড এ প্যাটার্ন ক্যান বি ডিউ টু সুপিরিয়র অবলিক ওভারঅ্যাকশন। সো ইফ ইউ, যখন আমরা স্কুইন্ট এক্সামিন করব, করো না করো, পরীক্ষার খাতায় কিন্তু লিখতে হবে ফর ডিস্টেন্স দিস উইথ আর এক্স, ফর নিয়ার উইথ আর এক্স দিস, ফর আপ গেজ উইথ আর এক্স দিস, ডাউন গেজ উইথ আর এক্স দিস। কেন এটা না লিখলে এক্সামিনার বলবে করেনি তো কিছু, ফাঁকি মেরেছে। সো ভি আর এ প্যাটার্নটা যে তুমি জানো, সেটা এক্সামিনারকে জানাতে হবে যে আমি আপ গেজ অ্যান্ড ডাউন গেজে মেজার করেছি। কী করে করবো? সেনের চারটাকে নিয়ে দৌড়ে ছাদে উঠবার মাটিতে নামবো? নট দ্যাট, মাথাটা নামাবো আর মাথাটা তুলবো, দ্যাটস অল। ওকে, সো এ অ্যান্ড ভি প্যাটার্ন, যদি ইনফ্রাঅবলিক সুপারঅবলিক থাকে তো কোনো ঝামেলা নেই ভাই, ইনফ্রাঅবলিককে কেটে উড়িয়ে দাও। ইট ক্যান বি টেনেক্টমি, ইট ক্যান বি মাইক্টমি, ইট ক্যান বি গ্রেডেড ডিসিশন। অর সুপিরিয়র অবলিকে পোস্টিরিয়র টেনোটমি অফ সুপিরিয়র অবলিক করতে পারো। আর যদি না থাকে দেন কামস দিস মাসেল শিফটিং, মিডিয়াল লেকটাস উইল গো টু দ্য এপেক্স অ্যান্ড ল্যাটারাল লেকটাস উইল গো টু দ্য বেস। ঠিক আছে, এটা খেয়াল রাখতে হবে। সো বি প্যাটার্নের ক্ষেত্রে মিডিয়াল লেকটাস যাবে তলায়, ল্যাটারাল লেকটাস যাবে হাফ বেলি ওপরে, আর এই প্যাটার্নের ক্ষেত্রে জাস্ট উল্টো। আর আমি ডিটেলসে যাচ্ছি না, বোর করবো না। আর লাস্টলি হচ্ছে কমপ্লিকেশনস একটু জেনে রাখতে হবে। যখন যে কোনো সার্জারি করলে, ক্যাটারাক্ট করলে জানতে হয় যেমন ড্রপ নিউক্লিয়াস আর এন্ডোপথ্যালমাইটিস, জাস্ট লাইক দ্যাট। সো এখানে দুটো জিনিস জানতে হবে, ওয়ান ইজ অ্যান্ট্রিয়ার সেগমেন্ট ইস্কিমিয়া, এটার জন্য জানতে হবে কোন মাসেলে কটা ব্লাড ভেসেলস আছে, কারণ তারাই অ্যান্টার সেগমেন্টে যাচ্ছে। সো ল্যাটারাল লেকটাস হ্যাজ 1, আদার 3 হ্যাজ 2, টোটাল 7 ব্লাড ভেসেলস। You can go for a vessel sparing surgery, but that is difficult. So never ever do more than 2 recti muscle surgery at the same sitting. That can cause antasegment ischemia. So second day you must see the patient, not for squint correction. Squint correction holo ki holo na se to pore 3 মাস ধরে তোকে জ্বালাবে। At least antasegment ischemia হয়েছে কিনা সেটা দেখে নে। মালটার ভিশন চলে গেলে কিন্তু কনজিউমার ফোরামে কেস খাবি। ঠিক আছে? আর সেকেন্ড হচ্ছে ডিউরিং সার্জারি। এখানে বসে আছে, আমি নাম করব না, টেরিজিয়াম সার্জারি করতে গিয়েও মিডিয়াল লেকটাস যে যায় তার এক্সাম্পল। আমি পাশের টেবিলে কেস করছি, হঠাৎ করে আমায় বললো, স্যার মিডিয়াল লেকটাসটা কেটে ফেলেছি। হতেই পারে না, টেরিজিয়াম করতে গিয়ে আমার মিডিয়াল লেকটাস কাটে থাকে। হ্যাঁ স্যার আমি কেটে ফেলেছি, বাট হতেই পারে না। তারপরে আমি অলমোস্ট অনার্সোপ পড়লাম, গিয়ে দেখলাম সত্যি মিডিয়াল লেকটাসটা নেই। এবং তারপরে আমরা খুঁজে বার করে বাঁধলাম, এবং অনিন্দা ম্যাডামকে লাস্টে জানানো হলো, ম্যাডাম মিডিয়াল লেকটাসটা হারিয়ে গেছিলো, সেটা কিন্তু আমরা বেঁধে দিয়েছি। এক্স্যাক্টলি, বিকজ এটা চলে যায় মাসেল কোণে। সো মাথা ঠান্ডা রাখতে হবে। যদি মাসেল হারিয়ে যায় লাপালাপি করে লাভ নেই, যদি খুঁজে পেলি ভালো, নালে ছেড়ে দে, পরের সিটিংয়ে সেকেন্ড সার্জারি করে দিবি, পেশেন্টকে বুঝিয়ে দিবি আপনার স্ক্রিনটা খারাপ হয়ে গেছে। সো উইথ দিস নোট, thank you very much for your patient hearing.
Thank you, Shumanta. It was wonderful to hear from you. Some comments from the panelists?
আমার একটা ছোট্ট দুটো টিপ বলছি তোমার কাছে শেখা। ফার্স্ট হচ্ছে স্কুইন সার্জারি করার আগে কিন্তু ট্রপিকাসিল প্লাস দিয়ে ডাইলেট করে রাখবে। দিস ইজ ভেরি ইম্পর্টেন্ট।
At least পারফোরেশনটা হলে ক্রায়োটা সেম সিটিংয়েই হবে,
সেম সিটিংয়ে হবে।
আর সেকেন্ডলি হচ্ছে ফিনাইলেফ্রিন, এটাও কমন।
আর সেকেন্ড হচ্ছে যখন স্কুইন কেস ইভ্যালুয়েশন হয়, অকুলার মুভমেন্ট ইজ ভেরি ইম্পর্ট্যান্ট। একটা হচ্ছে ডোয়ান সিন্ড্রোম, সেটা তোমরা ভাবছো নট কমন, বাট ইট ইজ ভেরি কমন অ্যান্ড সামটাইমস উই মিস ইট। সো দিস টু ছোটো ছোটো টিপস।
Thank you. Sir? Okay, questions, please.
ইনফ্যান্টাইল ইসোট্রপিয়া কিন্তু আমার মনে হয় যত কুইক তুই পাবি তত কুইক তুই সার্জারি করবি।
As early as possible.
As early as possible. As early as possible. যত
Later
তাড়াতাড়ি
on,
at
it
least
becomes a cosmesis, nothing else. So,
At the time
as
of diagnosis.
yes, at the time of
at the time of
Like-
diagnosis, you ask for GA fitness. Without GA, you cannot do this.
means 18 to
Minalda will
24
run from
months
here.
was the way.
You will go to Khidirpur.
Nice presentation.
First Osim sir এর কাছে। Osim sir,
I,
আমরা যখন
I,
PGT
I
ছিলাম,
used
তখন
to
squint and
do
retina
the
চলতো।
squint in my the initial period of West Bengal education service in the year of 2000 to 2005, 6, 7. But now I'm not doing, but it is my experience because I gave the squint operation to Mono PGT. I do not take his name, but now he is very renowned surgeon. And the muscle has been lost, and the medial rectus has been lost, and it was after 7 days, and we did MRI or beat, and then the muscle stump was detected, and this was tried with the under J. That muscle has been taken and again to be sutured, and it was a and another result was there. Definitely it was experience. So muscle handling during your squint surgery is to be very, very, very meticulously done. Thank you very much.
Thank you, sir. Thank you, sir, for that excellent comment. Now we will invite Dr. Love Kochgave. He needs no introduction. He is one of the most renowned pediatric ophthalmologists in Kolkata. He will be talking about myopia progression. This is a hot topic in pediatric ophthalmology right now.
Thank you, Anuradha. How much time do I have? 10 minutes. So I'll try to finish fast. First, just 2-3 questions. Suppose infant comes and maybe preschool child with a myopia of 1 diopter or 1.5 diopter. What will you do? Can anyone answer? Prescribe spectacles or not?
It can be yes or no. What do you think? Yes.
Why? It will be no, because see, a small child, a preschool child, his universe is intermediate zone, and intermediate zone at -1 or 1.5, the child will have a good vision. So we can postpone it to school going age, and after school going age, maybe 3.5 years, and then if you have a significant myopia, it should be prescribed. Before that, if it is infant, maybe 5 diopters or more, then that the chances of amblyopia is there, then it has to be done. Otherwise, we can wait. So we'll go to a more important topic, which is very high chances that you will be asked. And second, it is a very important topic for any practicing ophthalmologist, which is myopia progression. Half of the time in your OPD, you will be answering, if you are seeing children, you will be answering these questions, whether the power will decrease with constant use of spectacles. I've been answering it daily for last 20 years. So, and how can we reduce the power and how do we keep it constant? So we should know answers of these questions and make it very clear to parents, because most of the parents think that using spectacle will reduce the power and the power will go. So that you have to tell them very clearly. Prevalence, these are for a theoretical part. What we are looking at is that the incidence of myopia may increase to almost 50% of children by 2050. So that it is going to be a very big problem in future. And when we are talking about myopia control, we are talking about preventing the onset of myopia and to retard the progression of myopia. So broadly, it can be myopia progression management can be divided into these headings, which is environmental considerations, optical methods of treating it, pharmacological therapies, and undercorrection of myopia. I'll go one by one. So let's go to the environmental conditions, and this is one of the most important thing is time spent outdoors by the children. And there are various theories have been postulated in this, which is that increased level of light outdoor. Outdoor is again in sunlight, not in evening time. Increases retinal dopamine and production release, which alters the gene expression in retina and reduces axial length elongation, which is one of the major cause for myopia progression. And this is one of the reasons, like children living in predominantly urban environment have higher risk of myopia because their outdoor activity is very limited. Rural children will have less incidence of myopia when compared to urban children. So there are various studies in various countries that has been done, and which actually correlates and it has been scientifically proven that more outdoor time spent by children over a week, maybe 20 hours, or the Australia study was done for 21 hours per week, and these children had a lesser prevalence of myopia. Second known environmental factor is increased near activity. More and more near use of digital devices, even books read at a very close distance for long hours has been shown to increase the progression of myopia. So this is, again, we have to keep in mind when we are advising our patients.
But that answer has to be very calibrated because children have to have their education also. So the directions what we give is generally to reduce digital screen time rather than studies, and don't go very close while reading books. The advice cannot be that not to read. So next comes the spectacles and contact lens. Various things have been tested, and we'll go one by one. One is the use of bifocal or progressive spectacles, and similar to undercorrection of myopic refractive error, the progressive spectacles are thought to reduce accommodative effort or to slow, and that leads to slowing of myopia. This is a theory which over time has been proven wrong. So there were various studies in which they studied children with progressive lenses, and in this the myopia progression was just less than 0.25 diopters over a 3-year period, which is not very significant. So simple progressive or bifocals, it is a plus minus. Like one group will say it works, one group will say it will not work. Similarly, what they found, one study found that the use of progressive lenses compared to single vision lenses was statistically significant in slowing myopia progression, but not to a clinical, to a clinically insignificant degree. It didn't have any effect on the practical aspect of it. Again, there are some contact lenses used which uses peripheral myopic defocus. This is one proven theory which has both contact lens and spectacles. Normally there is a peripheral hyperopic defocus, and peripheral hyperopic defocus leads to faster axial length elongation. So if you make it a peripheral myopic defocus, then chances of myopia progression will be less. This is another thing that has been tested is orthokeratology, which is reshaping of the cornea with contact lens. These things you should know, because if you get a theory question, you will have to write this. Practically, it is not being used. And the disadvantage of this is that on discontinuing the treatment, it has always been found that it regresses back. Again, another thing that has been tested in a similar way is a gas permeable contact lens. This is important because this is a newer technology which has come, which is defocus lenses. The defocus incorporated multiple segment spectacles. Nowadays, some of the leading spectacle lens companies have come with these lenses, in which the central part of the lens is for distance, and all the surrounding area is a small circular defocus lenses, which leads to a myopic defocus. It reduces the peripheral hyperopic defocus, as we have already discussed, and which retards the axial length progression and leads to slower myopia progression. So, but the flip side of it is that it's very costly, and with such a frequent change of refractive error in children, it becomes very difficult. Now, the most important in what is being used now is the pharmacological therapies, and these are mainly atropine group of drugs which causes cycloplegia and mydriasis. And options what we have is atropine. Atropine, now these are important studies which you all should know: ATOM 1, ATOM 2 and LAM study. So I'm covering ATOM 1 and ATOM 2. LAM you can just go through when you are going through this topic. So ATOM 1 study, what they did and mostly conducted in Singapore, they used 1% atropine, and the treatment period was 3 years with 2 years of treatment period and 1 year of washout. So what they found at 2 years was that there was a significant reduction in the mean progression of myopia, and also has a strong correlation with reduction of axial length in the atropine group. No severe side effects, but as you know, 1% atropine will cause dilatation of the pupil, and After 3 years, there was a significant rebound seen for both the myopia progression and axial length elongation after the cessation of the drug. So this in short is the ATOM 1 study. Now, the more significant is the ATOM 2 study, in which lower concentration of atropine was used, and historically also it is important. We have to understand how we came to the present atropine 0.01%, what is being used. So, in this, they studied 0.5, 0.1 and 0.01 dilutions. So, they included myopia less than -2 children, 6 to 12 years of age, and the children were divided into 3 groups in which 0.5, 0.1 and 0.01 were used. What did they do? They treated these children for 5 years. First 2 years was treatment, 1 year washout, and next 2 years during the washout period, if some children were progressing, then next 2 years they were again treated. So what they found was that all these 3 concentrations helped in reducing myopia progression, and it was dose dependent. But myopia 0.01% had similar efficacy, almost similar, but most important point in 0.01% was that rebound myopia was least in the 0.01%, and that is why it came into use in the present form. So, as you can see, no rebound was seen for axial length in 0.01%. In higher concentration, generally rebound is more. Next, coming to this, again, this is a very controversial because actual studies have shown that undercorrection of myopia leads to faster progression. So even if you are writing this point, you have to tell that data suggests that undercorrection over a long period of time, it leads to a faster myopia progression rather than actually retarding it. So we'll skip this. And so to conclude, what evidence do we have in myopia progression? First, most important is outdoor activity, increased outdoor activity in children, low dose atropine, and peripheral myopic defocus lens. These are the 3 things which we have at present by which we can retard the progression of myopia. Thank you so much.
Thank you, sir. Thank you very much. This atropine 0.01%, I would like to know the comments from the panelists. Dr. Pinaki, would you like?
It can be used, it should be mentioned. How long it can be used, Kitro or low dose myopia, it should be mentioned.
What a sponsor?
ARETS. How long it should be used, it should be mentioned clearly, so that the PGTs can use the thing.
2 years. See, first time whenever you are treating these children, the drop has to be used for 2 years and the compliance has to be good. And before starting this, is always better to check the axial length of the child, so that when the child comes to you for follow-up 6 months to 1 year later, you can compare the axial length.
Thank you, sir. Next, we will be moving on to childhood glaucomas, one of the most important topics in exams, and it will be covered by Dr. Tania Badru. She doesn't need any introduction to you people. So, any comments? While she is setting up her laptop, can we have some comments from you, Shuraj?
Yes. See, this childhood glaucoma thing, definitely it is important in both aspects. For your long questions also, you will definitely get it. Very difficult, you are definitely not going to get it in your Viva or any long cases. But the thing is, when long question, definitely few things you have to mention about the prevalences, definitely, and what are the 3 types of the glaucoma, and the current management. The management is changing now. There is a paradigm shift in the management. It is surgical, definitely newer surgical techniques are coming. So definitely concentrate on that part also. And for theoretical aspect, about the genes involved in this primary congenital glaucoma, that you have to know. Okay? So concentrate.
Thank you. Tania, please proceed.
So good evening everybody, and special thanks to OSWB for giving me this wonderful opportunity, and special thanks to Ashim sir, Manish sir and Anuradha di. So today now I am discussing about the childhood glaucoma. So classification. The childhood glaucoma is classified in multiple ways, but the most simplified classification, it can be divided into the three groups. The first is a true congenital glaucoma. That means in this age group, the patient have an elevated IOP in the intrauterine life and the incidence rate was on 40%. Infantile glaucoma usually present before the ages of 3 years. Incidence is 55%. And the juvenile glaucoma usually 3 to 16 years. Some book tells is less than up to 45 years. The gonioscopy reveals normal, or sometimes the gonioscopy reveals the trabecular dysgenesis. So earlier the presentation, more severe there. So now come to the Shepard-Swiss classification. The primary congenital glaucoma is divided into various groups. The first is in primary congenital glaucoma isolated, so the patient do not have any ocular anomalies or any other systemic anomalies. Next, the glaucoma associated with an other ocular anomalies like an aniridia, Axenfeld-Rieger syndrome. So you have to check, you have to see with a slit lamp. Next is an glaucoma associated with systemic anomalies like a Sturge-Weber syndrome and neurofibromatosis. And next is a secondary glaucoma. So the history taking is very important. So any history of trauma or any history of steroid, because in our countries there is a misuse of steroid, especially in pediatric age group. There is a vandal conjunctivitis example. So the clinical presentation. The most clinical presentation in congenital glaucoma, the symptoms are epiphora, photophobia, and the blepharospasm. And the early signs that is first noticed by the parents, the corneal haze. And if we examine the baby or kids could not open his eyes, even in normal lights, and constant watering. Next is an buphthalmus. Buphthalmus is very common, is less than 3 years of age, because the sclera is very elastic. For this reason, high IOP, there is an increase the size of the eyeball, result in buphthalmus, and is the sclera is a stretch, the underlying uveal tissue is seen, so the eyeball take on the blue appearance. Next is an Hofstra. Hofstra is very important. It is an healed breaks in the descemet membrane, that is an horizontal curvilinear line, and that should be differentiated from the true forceps delivery where we seen the longitudinal lines. Next is an optic disc cupping. So any pediatric age group, the optic disc cupping more than 0.3%. In this case, we have to exclude the other causes and we have to confirm the diagnosis if the patient had glaucoma or not. And next is a progressive myopia. If the patient have a progressive myopia, frequent changes of glass, so in this case, we have to rule out the congenital glaucoma. So now come to the presentation. Usually 1 in 10,000 birth, 65% are boys and 75% bilateral and often asymmetrical. So the rule of thumb. So what is rule of thumb? Pediatric glaucoma, especially the juvenile glaucoma, are the high pressure glaucoma. In the pediatric age group, the IOP usually up to 15 mm. More than 15 mm is considered the patient have a congenital glaucoma. If the childs come with a corneal edema, low IOP, then you have to consider the other possibilities. Then you have to check the CCT. If the CCT is more than 1000, then there is a more chances of congenital hereditary dystrophy. So the congenital glaucoma or pediatric glaucoma are the high pressure glaucoma. So the clinical evaluation. So you have to evaluate it under sedation, under anesthesia, proper consent, take the patient to then proper counsel the patient party, and with proper consent take the patient to the OT, and with a proper expertised anesthetist. The first during anesthesia, during induction, the first check the tonometry with an Parkins or tonopen, because we use the ketamine or we use the some drugs that causing increased IOP or lowering of IOP. For this reason, there is an overestimation or underestimation. So that is very important during the induction. The first you have to check the IOP within Parkins and tonopin. Then the corneal diameter, then the direct gonioscopy you can use, or you can use Swab-Jacob lens or any indirect or any indirect gonioscope. Next is an axial length and the pachymetry and disc and retina evaluation. So this is table. This table is very important for confirming the diagnosis. This take from the Shields anatomy. You have to go through this table and take it to the OT and paste it to the OT table, and that helpful. If the baby have more than 2 years, then the corneal diameter less than 12, that is normal. If more than 13, then suspicion the patient may have an glaucoma. And this is also table that is for normal intraocular pressure is like in 2 to 3 years of age, normal IOP is in 12.6. If the baby have an IOP more than 16, then patient may have an glaucoma. So this table is very important for confirming the diagnosis. So now come to the differential diagnosis. The first is an NLD obstruction. In NLD obstruction, there is no photophobia or no other symptoms. The IOP was normal and the disc normal and other findings or parameters normal. In case of megalocornea, very confusing megalocornea, but in megalocornea, the patient usually asymptomatic and the IOP is normal. And very important, that is a congenital hereditary endothelial dystrophy. In this case, the baby come with a corneal edema, photophobia present, but in CCT, there is an increased CCT thickness, the more than 1000, but the IOP is low. So the diagnosis is congenital hereditary endothelial dystrophy. So now come to the managements. So the primary management in glaucoma, congenital glaucoma is a surgical. Because all of you know, in congenital glaucoma, the main pathology behind the congenital glaucoma is there is a trabecular dysgenesis and also there is a high insertion of the iris. So there is an anatomical abnormalities in congenital glaucoma. So the surgery is the main aim of treatment. And medical management is the next. If the surgery or after surgery there is not a lowering down the patients, then we prefer the medical management. The first, the beta blocker. Beta blocker, during the application, the beta blocker counsel the mother, and when you are applying the drugs, close the eyes, block the nasolacrimal duct, and if the baby develop any coughing reflex or any respiratory distress, please discontinue these drugs. Next is a carbonic anhydrase inhibitor. This is the safest drugs, and never use the brimonidine because less than 5 years, because it causes the CNS depression. And prostaglandin analogs and the pilocarpine is less effective because before surgery, because in congenital glaucoma, there is an altered anatomical structures. For this reason, the prostaglandin and the pilocarpine is less effective before the surgery. So the surgical management, first is goniotomy, trabeculotomy. Normally in Western countries, the goniotomy and the trabeculotomy is the preferred treatment, but in our countries, we prefer the trabeculotomy and trabeculectomy. So why goniotomy? Not because in our country, all the cases present late, and the goniotomy needs the more expertised hand. And the trabeculotomy and the trabeculectomy. So what is the trabeculotomy? So the trabeculotomy means making an incision over the roof of the Slem's canal and direct communication with the Slem's canal to the anterior chamber. So this is called the trabeculotomy. So trabeculotomy, you can take care of the angle, and the trabeculectomy, we increase the outflow pathway. So this is the dual mechanism that use normally the trabeculotomy with trabeculectomy. Next is then glaucoma drainage devices, and next is ciliary ablation. So we almost never perform goniotomy because already said our patient present late, lack of proper training, and the success rate less than 1 month is 26%, more than 2 years 36%, and 1 to 12 months nearly 70% of success rate. So this is a surgical video of trab in a 6-month-old child of congenital glaucoma. So the corneal stay sutures was given for the better exposure. fornix-based conjunctival flap dissection, then episcleral vessels cauterized, then scleral flap dissection. This is very challenging step in congenital glaucoma because sclera is very thin. And the next steps that is very important, that is the identification of the Slem's canal. So to identify the Slem's canal, the high magnification identification we identify the Slem's canal. So Slem's canal lies in the transitional zone and the interscleral vein drains into the Slem's canal. So the roof of the Slem's canal is incised and check there isn't any dribbling of aqueous or any dribbling of blood come out. That means that enters into the Slem's canal. If the gush of fluid come out, that means we enters into the anterior chamber. Then increasing the size of the Slem's canal, then for the better introduction of the humped trabeculotomy, then the humped trabeculotomy is enters into the Slem's canal, rotate anteriorly and breaks the Burken's membrane that is overlying the trabecular meshworks and enters into the anterior chambers. So there is a direct communication between the Slem's canal with the anterior chambers. Now the next part is in trabeculectomy. The anterior chamber is entry with an keratome, then the punching was done and the PI was done to improve the outflow facility. So the reversal of cupping, so that is very important. The examiner asks question frequently. In pediatric glaucoma, the cupping is reversible, whereas in adult glaucoma, the cupping is irreversible. So why? Because in pediatric glaucoma, the sclera is more elastic. Due to high IOP, the sclera, the eyeball enlarges, the enlargements of the scleral canal, posterior bowing of the lamina fibrosa that compress the optic nerves and lead to the cupping. When the pressure is come down, then the release over the optic nerves less, and then so the cupping is reversible in pediatric glaucoma. So the glaucoma shunt indications where failed valve, failed trap, scar conjunctiva, secondary glaucoma, aphakic and pseudophakic glaucoma, Sturge-Weber syndrome, IC syndrome, and the glaucoma following the PK and RD surgery and uveitis. So this is a live surgical video of a child with an aniridia. So the first, the corneal sage suture were given. After that, fornix-based conjunctival flap dissection. Then episcleral vessels cauterized. And the plate of the valve is placed 8 mm away from the limbus and anchored to the underlying sclera, and the tube of the valves is cut in such a way that allow the entry 1 to 2 mm into the AC. Fast forward the video, fast. And after that, the scleral punching, after that, the tube of the plate was anchored to the underlying stela for the better fixation. After that, the scleral patch grafting was done. So pediatric available shunts, that is an FP8, that is an valve mechanism is better, and other is an KP Mehta valves, and that is in pediatric age groups, and also newer is an oro valves, that is in cheap. Next is a surgical success rate 56 to 95%, and follow-up more than 5 years with good success have been reported. So cyclodestruction, aphakic, advanced aphakic or pseudophakic glaucoma, neovascular glaucoma, and patient who have had a penetrating keratoplasty. So the very important step in pediatric glaucoma is a treatment of the amblyopia. In spite of lowering down the pressure, if we not prescribe the proper glasses, still the baby lose the visions. So the cycloplegic refraction is very important at the 1 month after the surgery when the eye becomes silent, and after the 6 months, and better to refer to the pediatric ophthalmologist. So that is better. So next is an persistent of corneal opacity. If the corneal opacity persists more than 3 months, then refer to the cornea consultant for the PK. So the counseling. So very important part of the pediatric glaucoma, childhood glaucoma, counsel. Counsel the parents. It is not a, and this is a lifelong disease, and and hope them, because the family member of the pediatric age group are very stressed out, because still now the glaucoma is a social stigma, and explain that's need the close follow up, and in every follow-up, you have to check the IOP, disc evolution, corneal diameter, axial length. So the conclusion, so the management of the pediatric glaucoma is a multidisciplinary approach. It needs the pediatric consultant, then glaucoma consultant, and the cornea consultant. So a well-equipped arsenal is needed to win any battle. So we need the cooperation in all front of to win this battle against the congenital glaucoma. Thank you.
Thank you, Tanya. It was wonderful videos. I would invite one comment from Dr. Manish Singh.
Thank you, Anuradha. I think Tanya has covered almost everything. There's one or two points I just thought I'll add, because a lot of time in exam you can be asked that what is the best surgery for congenital glaucoma, and if you see the textbook, it is always written goniotomy, because you are not dissecting the conjunctiva, so it is the best option. But in India, when you see examiners, they want to know trab or trabeculotomy with trabeculectomy. And this is very India-specific answer, because in no Western book you will find trab as the best answer. If you go by the history, this surgery was actually started by Professor Anand Sood in RP Center, in AIMS. And sir used to do trab, and Dr. Anil Mandal was his student. He learned from him, and he used to do trab in LV Prasad, and they published the longest series in the world of congenital glaucoma. I think now almost 1500 cases they have. And their logic was ki in India we get patients who are presenting late, so the cornea is edematous, you can't do coniotomy, so you do trabeculotomy, but sometimes you can't do trabeculotomy also because the sclems is stressed, it is difficult to dissect, so you do trab also. So ye nahi to wo, something will work. That is the way it was started, and then in India most of the center, whether it's Shankar Netralaya or AIMS, even we are doing. But if you see the international books, it is always a goniotomy as the first option. If the cornea is hazy, then trabeculotomy. If they fail, then generally the next option is a trab. So this, you want to add something? So this is one history, why in India it is so specific, trab we always say. And brimonidine, she has already highlighted, it's a very common question that you should not use brimonidine less than 5 years, some books says less than 7 years. 360-degree illuminated microcatheter is also available now, which with you can do a 360-degree trabeculotomy. So for exam point of view, you should be aware of that. We talk about MIGS, minimally invasive glaucoma surgery, which is mainly recommended for open angle glaucoma, not for congenital glaucoma. But there is a type of MIGS, which is the gonioscopy assisted transluminal trabeculotomy. You can get in newer textbooks. This is something which can be done in a pediatric glaucoma or juvenile glaucoma also. These few things I wanted to add.
Manish, one question. Now you have from your earlier cases, you have almost 17, 18 years follow-up. How are they doing now? These children who are were operated.
So I tell you one thing, the patients where patient presented early, we operated them early, and we were able to do a good trabeculotomy. We were able to cannulate these claims, we were able to create a good communication. These patients over time have done better compared to those patients who presented much late, much advanced glaucoma with corneal opacity. Those patients didn't do that well. Plus, if it's a primary congenital glaucoma, they tend to did better. Compared to say an Exen Fields or a Peters anomaly, their patient didn't do that well. So again, very important thing is, in start of your practice, I personally will suggest you don't start with congenital glaucoma. You need a team. You need a place like an RIO or a Disha or a, say a Shankar Netralaya, because you want a cornea consultant around, you want a pediatric ophthalmologist, you want a good GA backup, you want a good team to handle these patients. And in congenital glaucoma, you are actually not treating the patient, you are treating the family. Remember this thing, patient is not at all bothered about your pressure. He's a kid. So I tell a lot of my patients, when you see the mother is crying or the father is crying, and you don't worry about the bacha, because For the kid, whatever he's seeing is the world. He's not bothered whether the pressure is 20 or whether he can see 6 or not. He's happy. The mother and father, the parents are extremely stressed. So you need to counsel them. Spend some time with them. Tell them that you have to be strong. It's a long journey. We have to require multiple surgery. But if we work hard now, if we give our best now, when the kid will come to the teenage, then the patient will be able to see. If you give up now, if you surrender now, then later on, the whole life the kid will live a life of a blind. So this is very important to counsel the family properly.
Thank you, Manishda. This is actually true for all the pediatric ophthalmology conditions because parents need to be counseled more. Now, moving to the next topic, pediatric cataract management, one of the very interesting topics by Dr. Tanmay Vishwas.
Thank you, Dr. Anuradha, and thank you to OSWB for giving me this opportunity to speak here from the place where I had done my MS. So coming back to my alma mater and presenting a topic which I love is great. So again, no financial interest. So I have designed this PPT in a way that it will help you to kind of structure your answer if you get a long question. So first of all, going to the epidemiology, so the prevalence of childhood cataracts varies from, I have given a range 1 to 15, 1 to 10 in different populations because it is different in every study. So different study gives a different number. So here you have prevalence in low economies is like this, high economies like this. In India is approx 8 per 10,000. So coming to the genetics and causes, so 1/3 of the cataracts are sporadic. So most of them are without any cause. So they may be unilateral, they may be bilateral. 1/3 are familial, mostly autosomal dominant with complete penetrance. So you will see the parents are coming, if the father or the mother might have a very thick glasses. So most likely they have also undergone cataract surgery in their childhood. So these are autosomal dominant with complete penetrance. So other causes are infection, metabolic, PHPV, traumatic. So next comes to the history. So you ask the parents what is the age of onset and other signs and symptoms. So like how will you ask what is the age of onset? The parents might tell you, हाँ तो बच्चा तो ठीक ही था, अभी 3-4 महीने पहले से वो चीज़ों से टकराने लगा है. The child may be not be able to spot little bit things like ants or maybe one piece of chocolate that has fallen to the floor. So these are clues that probably the child is not seeing well. So the parents will be able to tell you whether there is any drop in the visual function of the child. So if suppose the cataract is congenital, the parents may not be able to tell in that way. So there comes a little bit different. So again, we have to take a prenatal history, that is any infection during pregnancy, what are the drug used in pregnancy, or if any exposure to radiation, postnatal history like trauma during the childbirth, any infection after birth or drug usage, and also family history. Just as I said, the parents might have had cataract surgery when they were young. So that gives a clue. Now coming to the ocular examination, it is a difficult part because children are not cooperative at all. Especially children who have visual deficit, they are more so. So you take the visual acuity. So this is again different upon the age. So very young children, you try to see the fixation preference. Sometimes if there is unilateral cataract, so the child will try to see always with a better eye, and if you close the better eye, the child will try to cry, whereas if you close the worse eye, there might not be any difference to reaction. Then there is a CSM methods for little bit older children, and then the teller acuity cards, the Lia symbols, and if and when the children are able to read the Snell's chart, you can go ahead with them. Try to look for nystagmus. It gives a very poor prognosis. It tells us that the cataract is present from a very young age, and even after surgery, the vision might not gain so much, but still you have to treat it. Presence of strabismus indicates the presence of amblyopia. So after surgery, the vision gain might not be good. So the parents will ask, क्या हुआ, operation क्या, कुछ तो फायदा नहीं हुआ. So if there is strabismus present, you will have to counsel that even immediately after surgery, the vision will not improve that much. But surgery is the first step. Without the surgery, you cannot improve the vision. So first surgery, then the treatment of amblyopia. So then comes the anterior segment examination. So the morphology of the lens opacity, whether it is an anterior lenticonus, it is very commonly associated with the Alport syndrome, whether it is a posterior lenticonus, whether it is a nuclear type of cataract, whether it's a sutural cataract, whether it's a blue dot cataract. Okay, if there is any other abnormality present in the anterior segment, you have to also look for that. Children may usually are very uncooperative for slit lamp examination. So how to see the anterior segment? So make the children lie down and wear the indirect ophthalmoscopy and use the 20 diopters of the indirect ophthalmoscopy as a magnifying lens. Go near the children and use the 20D as a magnifying lens to see the anterior segment. And last but not the least, the most important thing is the dilated fundus exam. And if the cataract is a total cataract, you cannot see the fundus. You have to do a USGB scan to see if there is any retinal detachment present. So why is it important? If you see if you see the fundus, if there is any macular abnormalities or a retinal detachment, then again it indicates a very poor visual prognosis. You will have to go ahead and do the surgery probably along with a vitreoretinal surgeon. So what are the further investigations? Obviously, since you are doing a cataract surgery, one of the important investigations in biometry and IOL power calculation. Now, we are not going into the details of the various IOL power calculations because that will take an entire half an hour, maybe an hour. So the various methods of IOL power calculation in children are one of the Dahan's formula, another is the NEAD's rule of 7. So NEAD's rule of 7 is what is the age of the child and the target hyperopia will add up to 7. So if the age of the child is 5 years, so you should target 7 minus 5 plus 2 of hyperopia. Then there is SRK-T, Hoffer Q, Barrett 2. So the thing is, there is no gold standard formula due to the growing eye. So what the accepted practice pattern is, we all target a low hyperopia to achieve, the aim is to achieve emetropia or low myopia in the adulthood. So suppose if there is 4-year or 5-year-old child, we target plus 2 or plus 3 hyperopia, the eye will grow. So there will be myopic shift. Slowly, we aim to have zero power at suppose 16 or 17 or 18 years of age when the eye will stop growing, but it is nearly impossible to achieve. So even if we aim for 0, if it turns out to be minus 3 or minus 4, that is still acceptable. But the thing is that to achieve 0, sometimes we have to target plus 6. So the problem with targeting plus 6 is the higher hyperopia, the more is the chances of developing amblyopia post-surgery, because hyperopia is more amblyogenic than myopia. So we target low hyperopia. So after surgery, the patient doesn't develop amblyopia. Then in the adulthood, we achieve low emetropia or low myopia. Even if we achieve high myopia, there are other interventions that we can go for LASIK or something like that to correct the myopia. So we should not target a very high hyperopia because that itself will produce amblyopia. So blood investigations. So not all patients require a thorough blood investigations. So children who come with a positive family history, just as I said, the father has a cataract surgery when he was young. So you do not need to do a detailed blood investigations like torch titer, VDRL like this. Okay, there are other ocular defects. So if you see something like there is a corneal defect and you can associate with a syndrome, or in the pupillary defect or something anterior segment defect, you can associate with a syndrome, or let's say unilateral cataract that has a persistent hyperplastic primary vitreous, you don't need to do a detailed blood investigations in this. Usually unilateral cataracts alone we do not detailedly investigate because most of them are sporadic. Other than that, bilateral cataracts, we sometimes investigate with complete blood count, blood sugar, urine for reducing substance, torch titers, VDRL, genetic workups to confirm Downs, Edwards. So the other investigations routinely required is, since it's a child, so you need a general anesthesia. So the investigations for general anesthesia, and obviously opinion for pediatrician and cardiologist, because they may have cardiac anomalies and they may have anomalies which will land you into huge trouble during surgery. So you definitely take a cardiologic opinion because so that you don't land up in a soup during the surgery. So what are the indications of surgery? Like in adult, we see a cataract, we just straight go ahead and operate. But in children, it is not so. You just don't see a cataract and you operate. So you have to weigh the pros and cons. See, in a children, once you operate, the accommodation is gone. Okay, now it is better to have a 20 by 50 vision with a good accommodation than a 20 by 20 vision. Okay, so the target is to avoid deprivational amblyopia and provide optimal visual rehab. So central cataracts are more than 3 millimeters in diameters, dense nuclear cataracts. Now, how to understand if those cataracts are visually significant? Now, a child has come 2 years old, cannot really read, not really cooperating. So, how to understand that whether this cataract is visually significant? So, you see the child undilated. You do a distant direct ophthalmoscopy. If the quality of the red reflex is really poor, then the cataract is really significant. Another is during the fundus examination, if your view of the fundus is poor, that means the child's view of the world is also poor. Okay, so if BCVA is better than 20 by 50, can wait for surgery because to preserve accommodation. If now loss of accommodation in children is a huge thing, so we have to think about ways to preserve the accommodation. So partial central cataracts or peripheral cataracts can remain stable for years. So you can keep observing them as long as they maintain 6/12 vision or good N6 or N9 unaided. That is excellent. So what is the timing of the surgery? So for unilateral congenital cataracts, the timing is 4 to 6 weeks of age. And for bilateral congenital cataracts is 6 to 8 weeks of age. Now you see the unilateral cases, the age is lesser because the chances of developing deprivational amblyopia is much more in unilateral cataracts. So that's why unilateral cataracts gives a much lesser time for you to go ahead and operate than the bilateral cataracts. The main challenge in these young children is to get a proper anesthesia. So the anesthetist will try to push the surgery thoda baad mein karo, but the problem is the later you do, the lesser the chances of regaining vision. Now the others, depending on type of presentation and morphology of cataract, if it's partial, you can really wait and see as late as possible. If it is a total cataract, you go ahead and do the surgery as early. So how pediatric cataract is different? There are various factors: intra-op, post-op. Intra-op, the smaller size of the eyes, the highly elastic anterior capsule, low scleral rigidity, dense vitreous, management of posterior capsule and vitreous. So the post-op is higher chances of post-op inflammation, tendency to develop amblyopia, and higher chances of glaucoma and retinal detachment. So the surgical technique that usually commonly followed is usually in less than 6 months, we'd go ahead and do a lensectomy and limited anterior vitrectomy without an IOL. At present, less than 6 months, we do not put an IOL. Between 6 months and 1 year, lens aspiration, limited anterior vitrectomy plus or minus IOL. Why plus or minus? Whether to put the IOL is decided upon the corneal diameter and the axial length. If the corneal diameter is more than 10 millimeters in this age, you can go ahead and safely put an IOL. If the axial length is more than 19 millimeters, you can put an IOL. If either of them is reduced, then it's better not to put the IOL. And for more than 1 year of age, lens aspiration and limited anterior vitrectomy plus IOL, again you have to look into the corneal diameter and the axial length. If either of the two is low, then it's better to delay the putting of the implantation of the IOL. Choice of IOL, usually the accepted standard practice is an acrylic hydrophobic IOL. Just like I said, plus special cases warrant aphakia. So reduce corneal diameter if there is an anterior segment dysgenesis or any other abnormality of the reduced axial length, it is better to keep aphakic. So good aphakia is much better. You give an aphakic glasses much better than putting in an IOL and developing glaucoma and complication, and the cornea becomes cloudy and this and that. Surgery is usually preferred through an anterior approach. Anterior approach means that you make the incisions through the limbus, but pars plana lensectomy is also an option, especially if the cornea is if there is associated abnormalities like sclerocornea, where the corneal diameter is 5 or 6 millimeters, or if there is any associated retinal abnormality. Suppose if you go ahead and do a retinal detachment, that has to also be done. So you can go ahead and do a pars plana lensectomy, usually done by the retinal surgeons, and then usually is kept aphakic. When we do the pars plana lensectomy, usually the patient is kept aphakic. So during surgery, what the plan of action, what the route of action is done is not all children are cooperative for biometry. So children who are not cooperative for biometry, those children are taken for on-table biometry. What is on-table biometry? We do the biometry under sedation. So during biometry, the keratometry has to be done first, followed by the IOP measurement with a Perkins or a tonopen. Then the endotracheal tube can be intubated. Then the rest of the UA can be completed. Why? Because IOP has to be taken before endotracheal intubation that you see in the box. Now, if we do the keratometry after the IOP measurement, those the Perkins that you make, they indent the cornea very little. Now that can give wrong keratometric values. Ultimately, you are putting the wrong IL power. So keratometry first, followed by IOP, ET tube intubation, and the UA. In the UA, what we do in the axial length measurement, corneal diameter, and the gonioscopy. So here is a video of surgery. So we are doing the side port with the MVR knife. Why with the MVR knife? Because those are very precise measurements and gives a snug fit. We're giving a little bit of dilatation of the pupil. Oh, sorry. So we are staining the anterior capsule with a trypan blue, then giving a high molecular weight cohesive viscoelastic. Now see, there is a central cataract. The first nick is given with a cystitome, and the rest of the capsular axis is completed with the microrhexis forceps. The frequent grab and re-grab is usually the principle. Then the lens is aspirated. You do not need any ultrasound energy in these cases. So the lens is aspirated with the vitrector itself. And see, the anterior capsule ring is nice. Now the posterior capsule, the nick is given in the posterior capsule. Little bit of visco behind the posterior capsule to separate the posterior capsule from the anterior vitreous face. And posterior capsulotomy is done. And limited anterior vitrectomy is followed. Now our hydrophobic IOL is placed in the bag. What is important is at the end, you have to suture all the ports. Okay, because in children the scleral rigidity is very low, the AC will collapse after surgery if you do not suture. So visual rehabilitation of aphakia, spectacles and contact lenses, they have their own advantages and disadvantages. So you have to assess in each individual case. So summary is thorough ocular and systemic exam, rule out systemic abnormalities for the safe surgery. Consider non-surgical options first to preserve accommodation. Impress upon the parents that the regular lifelong follow-up is needed. This is most important. Always remember, surgery is not the end, it's just the beginning, it's the first step of the rehabilitation. And these children, when they grow up, they will need a lifelong evaluation, because these children have a 30% of chance of developing glaucoma lifelong and high chances of developing retinal detachment. Thank you.
Thank you, Tanmay. We would like to invite some comments from our panelists.
First important thing is that after the operation, that is the cataract operation, as Tanmay said, your job is not finished. In fact, the job is started. Because if you have given the patient emetropic, you have kept the patient emetropic or hyper, or what he said, as the child is having myopic shift. Suppose the patient is hypermetropic, you have kept because of the myopic shift. Now you'll have to follow up for the amblyopia. Most of the time what happens? Patient you have operated, you also that operation ho gaya khatam aur kichu korte hobe na. Patient asche chashma pache ki na, refraction hocche ki na. That is the most important thing. If it is ignored, all surgery, everything is all in vain. Again, amblyopia will develop. So now amader যখন স্টুডেন্ট ছিলাম আমাদের ছিল কি হাইপারমেট্রোপিক রাখতে হয়, তাই তো আমরা তাই পড়েছিলাম। এখন it is changed. Low means we should go for the possible emetropic. তাই তো তন্ময়, তাই তোমরা করছো, emetropiaই রাখছি या low hyperopia. Then তো that is like the adult eye.
low hyperopia, not emetropia.
তো এখানে কি হচ্ছে, তোমাকে এমলাইপিয়ার জন্য all the time you will have to follow up the patient. This is very important. Either আর most problem কখন হয়, যখন uniocular surgery হয়, unilateral cataract হয়। In case of the unilateral cataract, the chances of amblyopia is more. এখানে আমাদের যা লেভেল অফ পেশেন্ট আমরা আড়াই হতে পাই, আমরা কন্ট্যাক্ট লেন্স দিতে পারি না। কন্ট্যাক্ট লেন্স দিলে ইজ গুড, আদারওয়াইজ অ্যাগেন ইট ইজ ডিফিকাল্ট। সো দিস ইজ দ্য মোস্ট ইম্পর্টেন্ট থিং। অ্যান্ড ফলো আপ জন্যে মোস্ট অফ দ্য টাইম পেশেন্ট ডেভেলপ গ্লুকোমা অলসো, যেটা আমরা জানি না। সো রেগুলার ফলো আপ ইজ ভেরি ইম্পর্টেন্ট হিয়ার। ঠিক আছে?
To the last speaker, oculoplastic conditions in children. Dr. Purban Ganguly doesn't need introduction. He is your teacher. Please listen to him.
Now, after a lot of strabismus and then congenital glaucoma, then pediatric cataract, this is really a torture. But then the entire residency is a torture if you do not know how to enjoy it. Now, what is the child conundrum? What is the problem with the child patient? First of all, it is time consuming. At the fag end of the OPD, a child has come, a weeping mother has come with a weeping child. It's a problem. Next is, it's a veterinary science, non-verbal patient. The patient cannot tell you anything. The third point is the parent trap. Those who are there in the corporate setup, we have the overconscious patient. And for us here, when we say your child might die, the response is, oh, okay, theek hai. So the parent trap. Next problem is the general anesthesia. The concept of general anesthesia is a kind of alien to the ophthalmologists. So the problem of general anesthesia and the unpredictability of the outcome. Now, what are the problems, oculoplastic problems with what the patient comes to us? Watering. This is the first problem, jol porche. The parent is also crying and the child is also crying. The child cries like that only. Then how come the patient is aware of the fact the child is having watering without actually crying is really a mystery to me. Pain and discharge, dimness of vision, white pupillary reflex, outward protrusion of the eyeball, and ptosis. The first conundrum is watering or epiphora. Now, the first thumb rule is that all road doesn't lead to congenital nasolacrimal duct obstruction. There are other causes of epiphora too. One is the hypersecretion. There is something is irritating the eye. It might be a misdirected eyelash. It might be a malposition of the lid. It might be a keratitis. It might be a conjunctivitis. All of them will water. So do not really pick on the innocent canaliculi and the sac for no reason. And the next is defective drainage. Of the defective drainage, the punctal atresia and punctal stenosis is equally important than a nasolacrimal duct obstruction. Now, this is all we have discussed. Now, we will come with the lid malposition, that is entropion. Now, we have, for entropion or ectropion of upper eyelid or lower eyelid, we have to identify what is the problem, which layer of the lid is defective or damaged, either due to birth trauma or due to developmental damage. Is it the anterior lamella, the skin, which is usually there in cicatricial cases in the child? The child had a burn, the thermal burn or something like that. Or is it the tarsal plate that is defective? Is it the retractors which are not working properly? Or is it the posterior lamella, that is the conjunctiva is not working? If we have not identified the etiology of the outward turning or the inward turning of the lid, then the treatment is not possible. The second is upper eyelid congenital entropion. This is, there's a more severe form of congenital upper eyelid entropion is there, which is called the tarsal kink syndrome, which is due to the malposition of the tarsal plate. If the upper eyelid is defective, in case either outward or inward, always think about the problem lies in the tarsal plate. If the tarsal plate is okay, then you search for the other causes. Now, the lower eyelid congenital ectropion, much more common than the upper eyelid congenital ectropion, and it is easier to diagnose. You get it more often, and often it is associated with epiblepharon. We'll come with the epiblepharon. The entropion, the most important thing that we have to understand is that it has got a genetic predisposition. The orbicularis might be defective along with the tarsal plate. The tarsal plate might be defective. The retractors might be disinserted, and there is a syndromic association. Down syndrome or other syndromes are associated. So just only correcting the eyelid malposition will not help. Now, congenital epiblepharon, these are all associated with entropion, which might lead to a misdirected eyelash. So only whenever there is a lash that is going towards the cornea, just only epilation will not do, or maybe electrocauterization of a lash will not do. In epiblepharon, what do you have? You have an extra fold of skin in the lower eyelid, which is actually causing the vertical turning of the eyelashes. So if you are epilating the eyelashes or electrocauterizing the eyelashes, you are not treating the cause. You need to treat the epiblepharon. Dystrichiasis, trichiasis, all these things, firstly we have to remember that simple epilation will not solve. You have to go in for a definitive treatment with the form of electrocauterization or laser or cryotherapy, where the bulb should go. If the bulb is not going, then the dystrichiasis will again come up. Now, for the medical therapy is for only mild cases and temporary measures, so the botulinum toxin and all that, but you need to do definitive surgery. Lower eyelid entropy on definitive surgery is you have to identify the problem, whether it is vertical lid laxity or horizontal lid laxity or the retractors are going. Accordingly, you choose the operation. Now, it's very difficult right now to explain everything. Upper eyelid ectropion is very rare. It's a very rare entity. Ectropion usually involves upper eyelid. It is usually associated with Down syndrome, or another very common cause of upper eyelid ectropion is overcorrection of sling surgery. While doing sling surgery, if you have overcorrected it, then you might get an ectropion. And the treatment needs to be customized. The anterior lamella needs to be treated or the posterior lamella needs to be treated. That you have to identify. Now, these are the spectrums. See, if you look at the second picture is nothing but uridoblepharon, where you are finding that both the upper and lower eyelid is you have ectropion, as if and there is telecanthus, as if the eye has been pulled apart. So here you need to do a complex surgery of both the lamella of upper and lower eyelid in order to give a cosmetic outcome. Simply putting on simply doing a syringing for this case will not help, because here the canaliculi, the anatomy of the canaliculi is not normal as it is there in a normal case. Because of the telecanthus, the canaliculi are much more straight. So if you are not correcting the telecanthus and meddling with the sac, you are actually doing harm. And see, the third patient is the epiblepharon, where the lash is vertical. It's very easy to treat it as a trichiasis, and you will epilate and electrocauterize, but then it will again happen because the lid, the epiblepharon needs to be treated. Marginal entropion is something that is coming up new in the field. A part of the lid is entropic, and congenital dystrichiasis also. So the important thing is that you don't need to put in the patient under general anesthesia for identifying the oculoplastic conditions. Simple, see the diffuse eyelid examination. Firstly, tell the mother that do not hurry. Feed the child well, and then do not put in the light directly on the child's eye. Do a diffuse eye. You can take help from your low vision aid clinic. You can use a simple magnifier to check it. It is not that you, for diagnosis, you will put the child under general anesthesia. Then again for treatment, you will put again the child under general anesthesia. At least diffuse light examination will help. And syrup Phenergan definitely. Now coming to CNLDO, the most important, you all know where is the block and what is it. Two things I would like to highlight, that with more preterm babies, more CNLDOs are coming up. But the happiest thing is that it is mostly self-resolving, spontaneous resolution. Anisometropic amblyopia, unilateral CNLDO, the treatment doesn't end with the baby stopped having watering. Please do a cycloplegic refraction again, as Shuman sir has said. Cycloplegic refraction will help you. And the important part is mostly the block is at the valve of Hassner, but sometimes at the level of the valve of Rosenmuller or at the level of sac you might get a block. So if it is valve of Hassner, you will get a mucopurulent discharge. But if it is at the level of the lacrimal sac, then the discharge will be a little more watery. But remember, it's not an adult. So doing a rho plus in a child needs to be you need to be cautious and gentle. Now, this is what you have got associated with CNLDO. You might get syndromic association. There might be telecanthus, lid coloboma, microphthalmus. So you need to have a comprehensive part. And the second thing is that punctal stenosis and punctal agenesis is always mostly associated reason for watering in a child. So you need to know what lies beneath. But for needing to know what lies beneath, nowadays MRI with special focus on lacrimal drainage system, if you write to the radiologist, then you need to know. If there is no drainage system down, there is no point doing a punctal snip and unnecessarily putting the child under general anesthesia. So this is first you need to do a dye disappearance test. If the dye is disappearing normally, then look for other hypersecretion causes of epiphora. If the dye disappearance test is negative, then the first thing is that you need to do, if the child is more than 1 year old, then you need to do a syringing under GA, probing and syringing under GA. If it is patent, then rule out functional causes of epiphora. If it is blocked, then do an endoscope guided probing. Now this is one important thing that I want you to convey. The message is that every ophthalmologist who is dealing with lacrimal sac in children should know how to do basic anterior nasal endoscopy. Do not believe on the ENT surgeon's view, because most commonly a cause of failed probing is that hypertrophic inferior turbinate. So if you see a hypertrophic inferior turbinate, you should be able to fracture it while doing the probing. And doing the probing under direct nasal endoscopic view also give you a kind of a freedom that, yes, my valve of Hassner has been passed, and you need to see also whether the NLD obstruction had a thick membrane or a thin membrane, and accordingly you can prognosticate to the mother or the parent also. So first is the massage. The most important thing that I want you please go and see in a YouTube video how to do a Krigler massage. Massaging, 96% of CNLD opens up if proper massaging is done before 1 year of age. After 1 year of age, you have to go in for probing. Probing can be done 2 to 3 times. If the probing is failed, then you need to do a silicone intubation. That also needs basic endoscopic technique to be known by the ophthalmologist. If the silicone intubation is also failing, then you need to do a DCR. And nowadays we can say that, I hope Rajesh sir will agree with me, you can do DCR in a child as small as 3 years old also. And balloon dacryoplasty is not very popular, and it's not being performed anymore. So this is the second conundrum, is ptosis. It's not impossible for me to go into ptosis now, but the most important thing that you need to know, that ptosis can also be associated with blepharophimosis syndrome and Marcus-Gunn ptosis. These are two different spectrum altogether. And in blepharophimosis syndrome, the telecanthus needs to be corrected. There has to be a double Z plasty along with the ptosis correction. Nowadays, we can do it in single sitting also, but mostly it is done in 2 sitting. The first sitting is double Z plasty along with telecanthus correction, and in the second sitting you do the ptosis surgery. And all ptosis is not congenital, and lid crease, presence or absence of lid crease is the most confusing thing that you usually confuse with. Even with the presence of lid crease, it can be a form of congenital ptosis, or even without a lid crease, it can be some other cause of ptosis. So you need to see, and always a ptosis patient should have squint evaluation, as madam has said, because you might be dealing with a paralytic squint or a ptosis associated with a congenital squint. And treatment of amblyopia, whether you will touch the ptosis in a child or not, that will depend on the chance of development of amblyopia. White pupillary reflex is the third conundrum. It's not possible for me to go into it, but one thing I would like to highlight, that this is a pediatric session. The second most common presentation of retinoblastoma is strabismus. It is better, in my point of view, it is better you have retinoblastoma as your differential in all cases of strabismus, and do a dilated fundus examination before going in for a surgery of the patient. It is better to be wrong rather than missing out a retinoblastoma and doing a squint surgery in such patient, because that will lead to this. And you don't want this to happen. The third conundrum is the last one, that is proptosis in children. The most common cause of proptosis in children is infective cause, that is orbital cellulitis. Children have got a propensity to develop sinusitis. Ethmoid sinus is the most common sinus involved. Medial wall lamina papyracea is the weakest thing. It gets broken and the infection comes in. It has to be preseptal or postseptal. And you need to diagnose whether it is preseptal or postseptal. It comes as a long question in the examination because preseptal is not life-threatening, but postseptal cellulitis is. There are a lot of tumors that happen in a child. It is given over here. I would like, since it is oculoplastic consideration, I would like to share my experience with orbital rhabdomyosarcoma, which is one of the fastest growing tumor. See, this child presented in Raiganj Medical College, and this was there was a huge medial mass. It was diagnosed as lymphoma by the radiologist. This is the one learning point, that you should never ever rely on the radiologist's diagnosis. You should be able to read your own neuroimaging plate. Now, it took about 2 weeks for the child. The ophthalmologist was suspicious that this is not a lymphoma. So it was sent to RIO. Within 2 weeks, the patient, when presented with RIO, this was the condition. So we had to perform a lid sparing orbital exenteration, and this is the post-orbital exenteration. Now, when the child had come, the child was very weak, unable to feed, and it was very pathetic condition. Giving a general anesthesia also becomes challenging for this kind of child. Another rhabdomyosarcoma which I will like to share with you, a small video. This is a botryoid type of rhabdomyosarcoma. So this is a botryoid type of rhabdomyosarcoma, but it presented late. So it was a presentation was there in the inferior orbit, and nowadays you know that we prefer to go to the transconjunctival route. I had discussed this case with Rajesh sir. So we went in, we did a lateral canthotomy and went through the transconjunctival route and tried to remove the tumor as much as possible. We are using electrode. This is 11-month-year-old child. So you can imagine the spectrum of oculoplastic consideration of pediatric ophthalmology that we say very easily. This is the far end spectrum of oculoplastic consideration of pediatric ophthalmology. Orbitotomy comes as a long question in your examination. The approaches of orbitotomy: anterior orbitotomy, superior orbitotomy, and inferior orbitotomy, divided into transcutaneous and transnasal, transconjunctival approach. This is a transconjunctival inferior orbitotomy. You can see the mass. The mass is not well encapsulated. We were trying to remove the mass as much as possible. While deep down into the orbit, you should stop using the cautery because the optic nerve might get damaged. I know sharp dissection is not allowed into the orbit, but we had to be quick because it was only 11-month-year-old child. We tried to remove the mass, and you see, after all these muscles getting lost into the orbit discussion, here the inferior oblique had to be salvaged because it is for the life-saving procedure for the child. And this child was so sick, unable to have feeding with an hemoglobin of very low. And this is the post-op. There's a little amount of lid edema, and the child, it's a botryoid type of rhabdomyosarcoma has come in the histopathology, embryonic botryoid type, and now the child is very happy, but he has to be followed up with these things. There is nothing to take home currently from this presentation. One only thing that you should take home while dealing with a pediatric child: please do not forget your empathy, especially for ocular oncology patients or oculoplasty children with oculoplastic condition, because the first goal is life saving, the next goal is vision saving, and the last goal is cosmesis. And thank you.
Rajesh sir is a doyen in oculoplasty, and we would like to have his comments.
You know, I think I'm still a student. So when you call me a doyen, I feel very old. So I'm not a doyen at all.
That is very, a wrong thing to say. He is actually.
I'm so glad that we have a teacher like Purvan here under Oshim Das' guidance, and you all are doing great work. A couple of pointers actually about nasolacrimal duct obstruction first. It is such a surprising thing that when I see patients, this kind of patients coming to the clinic, people have been advising them about various types of massages, and these massages are a sight to behold, and the various types of massages. None of them are doing them right. So, please follow the right technique.
Sometimes they're shushuri actually.
They'll give you some kind of mirth and merriment in your busy clinic. But it's very important to have the right kind of massage, as Dr. Ganguly mentioned. That Kriegler's massage, which has been modified a questionnaire, is still the standard massage that we should follow. So please check up the YouTube videos, because it does work if it does properly. And then, as you mentioned, that doing an endoscopic guided probing is actually now the standard approach. And if need be, you have to do an infracture of the inferior turbinate. How do you do that? Basically, if you have a thickened inferior turbinate, you insert a Freer's periosteum elevator along the side of the nose, lateral side of the nose, and then you just press the inferior turbinate down. Idea is to create the space. The middle meatus should be opened up, widened up, so that there is enough drainage. Second thing is that I would like to mention, in a watering eyes, please also do a cycloplegic dilated refraction and see the fundus, because a fundus with a watering eye, if it's not blocked, as you said, tear duct, can have something very nasty lurking inside, as a pediatric ophthalmology colleagues will agree as well. You also asked about the rhabdomyosarcoma. I think we get a lot of patients with orbital cellulitis. Remember, orbital cellulitis actually can be a rhabdomyosarcoma in disguise. So don't forget that. So you have to have a high level of suspicion. And other things Purban showed, they're all absolutely tip-top, all the ectropions and entropions, fabulous photos as well. So great, and great surgery done as well. Thank you. Thank you so much.
Sir, please give the vote of thanks. Please.
Please wait for a group photo with the panelists and speakers and all others present here. And I am very happy that Pediatric Ophthalmology update program has successfully been ended here. But the speakers are very much interesting to speak. In my teaching time, if Sita was a student of MBBS, mostly in the year of 98, 99. And then Shuman was my student in MBBS. I used to teach them in this manner. Pediatric ophthalmology, it is vast but related subjects. So that when there is a presentation of the white reflex behind the pupillary pupil, mostly the cataract is a presenting answer. But all cataract does not alone be associated. There may be, behind the cataract, there may be retinoblastoma, other tumors, and also other pathologies. You have to be very cautious about the diagnosis and other investigations to be done. And squint may be present in the early childhood, and that mostly the esotropia, if Sita says very well, and there may be a condition where there is the retinoblastoma, and the Purban has said retinoblastoma also occurring at the macula, that may be presented with a squint that has got similar to the concomitant squint, but they have got to be separated probably for the treatment and also for the prognosis purpose. And then the paralytic squint, sometimes the child, when occurring after 5 to 6 years of age, they the child presenting with some abnormal in the head posture, and then some amount of amblyopia is associated, peeping their head backwards to see. And these are the commoner findings that may sometimes help for. And the myopia, and that common is that nowadays the textbook does not mention the myopia should be corrected or over-corrected, or it always written under correction is going on still. In Kansky's textbook and also Persin's textbook, those who are being usually followed. But it is a very study has come. Probably we are awaiting that the medicine that may be helpful for correction of the myopia in the lower grade for the child 5 to 16 years old. And all presentation are very good. I am very happy with my students here, those who have presented here very neatly and efficiently. I have got Anuradha also. So that I at first now the situation comes, my duty is to give some thanks for all the speakers. OSWB the post bearers, the secretary, president, and our scientific chairperson, we are all being remember their names in this evening, and they have arranged so much beautiful program here, and also the speakers love Ipshita and Purban, Tanmoy. He is also my student in the year of 2008 or 2007, mostly হ্যাঁ তা ঠিক সে they he is also doing very good work. Only he complaining that I am not referring the patient to Tanmoy, only to Anuradha. And definitely it is a much privilege for myself to send the patients to my students who are now master in the ophthalmology segment. And I also thankful to the panelists who are present here, Rajesh, Dr. Ghosh, and Dr. Pinaki, he is my colleague also, and Shriti, he was also student in this respect. He was a student of MS in PG SSKM, used to come here, and Surojit, all, and also Manish, and moderator Manish Aruradha. And lastly, I am thankful to Microvision for their nice cooperation and help for the beautiful program has been successful, and Giri Babu and Shogato Babu for audio visual help here, so that we can end a good sound system and also microphone, all the computer works, and all the presentation that has been sincerely shown to the audience. And also I congratulate and thankful to my students who have come from different colleges, and those who are also Sagar Datta and Kollani. Kollani, you have come, no? From Kollani? No, Sagar Datta has come, Shushrut has come, and PG SSKM, and other colleges who are NRS college. Rupam আমাদের এখানেই ছিল, but now he has been transferred to NRS Medical College. So thankful to all who are present here from the very beginning to end and successful PG update in pediatric ophthalmology. Thank you very much. Please come here to we are all together to take a photograph. এটাকে একটু সরাতে হবে।